Good afternoon. This is Susan Lynn Osterly, the VBID Center Program Manager. I'm pleased to welcome you to the 2022 VBID Summit. I'd like to take just a moment to go over some logistics. We would like the summit to be as interactive as possible. Send questions and comments via the question bubble on the control panel, as you can see here. And now I'm very pleased to introduce Dr. Mark Fendrick, the Director of the VBID Center, to start the summit.
Thank you, Susan Lynn. Good morning, good afternoon, good evening to this year's VBID Virtual Summit. Very sorry we can't meet in person in the big house, the University of Michigan Football Stadium this year, but I am more than happy to welcome people from across the United States, North America, and even a few people in Europe to this year's event. There are over 1,200 people registered as I see people rapidly clicking in. It's been quite a journey for us at the VBID Center since our first event in a snowstorm in 2005. But since that time, with a very broad array of healthcare constituencies and stakeholders, we have pushed to improve the access and affordability and enhance equity of high-value clinical services. Primarily, we have focused on the creation of lowering consumer cost sharing and creating pre-deductible coverage for high-value services, focusing on preventive care, insulin, chronic diseases, focusing more recently on maternity care, trauma, and specifically for the past few months, we've been focusing on the issue of cancer screening. And we have found recently that although 150 million Americans now have enhanced access to preventive services like counseling, vaccinations, and cancer screenings, several people who undergo a free cancer test are in fact not fully covered if their first test is positive, putting them potentially in financial hardship to complete the cancer process. And you'll see in the chat, as you'll see throughout the day, resources that our panelists, as well as the VBID Center, have been working on the issues that we will talk about, such as reducing underinsurance and cost-related non-adherence, talking about the expansion of VBID principles in public and private payers, and our focus, of course, to identify, measure, report, and reduce low-value care, in the fact that our tagline as we move forward in 2022 at the VBID Center is to rob low-value care Peter to pay high-value care Paul, in the fact that we could create headroom and allow more generous coverage and access for millions of Americans if we were to get serious about no longer paying for those services that at best don't make Americans any healthier and at worst actually cause harm. So before I hand it over to our moderator, as always, Dr. Cliff Goodman in a minute, I'd like to thank Susan Lynn Osterly and the VBID Center staff for their incredible work getting us to the point we are today and keeping the VBID Center moving and very accomplished through the past 2 years of this pandemic. I want to thank all the panelists in advance for their preparatory work and the contributions they have made to improve patient-centered outcomes, enhance equity, and lead to a more just and efficient American healthcare delivery system. I'd like to also thank Cliff, which I'll get to in a second, but turn to our next slide, which lists the sponsors and supporters of the VBID Center and the summit today. And I think if you look at that list of constituencies, you'll see this very rare, strange bedfellow coalitions of health plans and health sciences companies and consultancies and not-for-profit patient advocacy organizations and professional societies. And it's just really been a terrific journey for myself and Mike Chernew, who co-founded the VBID Center with me in 2005, who will close out the day. But I'm extraordinarily excited for a robust discussion, and there is no one better to lead us through that discussion to my friend and close colleague, Cliff Goodman. So with that, Susan Lynn, I'll turn it over to Cliff.
Well, thanks very much, Mark Fendrick. Great to be on with you today and in this extraordinary series of VBID summits. And as Mark said, we hope to meet someday soon in the big house, but today we'll go virtual and Very glad to be doing that. Here's our agenda for today. We've got 4 main sessions here. And the first one's going to take a look at how we go about reducing healthcare disparities and enhancing equity from the standpoint of a major foundation and a federal agency with which you are all familiar. We're next going to move to expanding the role of supplemental benefits by public and private payers. And it's always interesting to kind of delve into supplemental benefits. What comprise supplemental benefits? Where are we with those? What contributions do they make to narrowing disparities and so forth? Very interesting area. After a 15-minute break, we're going to take a look at what progress we've made in measuring and reducing low-value care. So we'll have some researcher scientists type on there to tell us how and how well we are doing in trying to close those gaps vis-a-vis low-value care. And then finally, for session 4, we're going to take a look at the problem of underinsurance and potential solutions. Now, something I want to point out that applies across these 4 sessions is this. None of this stuff is stable now. We have yet to reach homeostasis along any of these. Too many factors are in flux. I won't go over the obvious ones. I think they're clear to everyone. Every time we're trying to address one of these issues, we're doing it while the plane is flying, while the tectonic plates are moving beneath our feet. Everything is in motion. So that's kind of a constant theme that you're going to see here today. With that, I wouldn't mind going to our keynote panel. And as you can see here, our keynote panel, our keynoters will be Drs. Dora Hughes and Lori Zephyrin from CMS Innovation Center and the Commonwealth Fund, respectively. I'm going to ask them to address strategies to reduce healthcare disparities and enhance equity from their respective perches, as it were. And as we always do at this event, we ask folks to introduce themselves by telling us who they are, where they are, and what is it about their current role, their current position, their current set of responsibilities that applies to the topic of this keynote session. Dr. Hughes, may I go to you first?
Good afternoon. I want to start by thanking you for inviting me to join the panel today. I'm always also happy to join my good colleague, Dr. Zephyrin, as well. And so I'm looking to share and to learn from our discussion today. As a physician, I care very deeply about issues of health equity and social determinants of health, what's happening across the range of underserved populations. It's been my pleasure to join the CMS Innovation Center. I joined in August of last year as Chief Medical Officer, which is my formal role. I advise and provide assistance across our models, some that are focusing on certain disease conditions, as well as different provider types in certain communities. But also as CMO, I was asked to lead the health equity efforts at the CMS Innovation Center, and that comprises a very significant and meaningful part of my role, particularly as part of CMS's overall strategy, but the CMS Innovation Center's specific strategy that we'll get into a little bit more later. Certainly, there is a singular focus on advancing health equity, and that is part of the charge across all of the groups within the CMS Innovation Center, across all of the different models and initiatives that we're supporting, and certainly that includes the VBED model itself. So again, it's my pleasure to join you today, and I'll pass the mic over to Dr. Zephyrin.
Thanks, Dr. Hughes. Over to Dr. Zephyrin.
Great, thanks, Dr. Hughes. Thank you for inviting me today. So great to see you, Cliff, and thanks for having this summit and conversation on this important topic. I currently serve at the Commonwealth Fund as Vice President for Advancing Health Equity. My career has really been focused on how to make systems better for the people in them, having had experience as not only a physician on the ground doing work in underserved communities and also global health, but also across the national healthcare system, as for example, the VA healthcare system, and really supporting change and transformation efforts. At the Commonwealth Fund, we launched the Advancing Health Equity program actually last year, and it really came out of a 6-month sort of internal strategy effort to really look and think about how we as a Commonwealth Fund can further advance and dive deeper in our work to advance health equity. Commonwealth Fund, we're a foundation, but also a think tank or do tank, and our audience tends to be health system leaders and policymakers. So what are ways that we can provide not only highly credible information that can really help advance health equity? And so in our program, it's really focused on the work across advancing health equity is cross-cutting across the entire Commonwealth Fund. And so whether we're talking about work in healthcare costs and access, and Dr. Sarah Collins will be on later to talk about that work and others, or whether we're talking about policy or Medicaid or delivery system reform, health equity is deeply embedded into that. But as we think also about our health equity program, where also our 3 focus areas are really how to promote health equity across healthcare delivery systems, how do we focus on equity impact of policies, including helping to drive payment reform as well, and also how do we address culture change as well, culture transformation, particularly changing the mindset of healthcare leaders and providers as an opportunity to significantly advance health equity and address systemic racism. So happy to talk more about each of those areas, and really happy to be here with all of you today.
Thanks very much, Lori. So it's good that both of you run big programs and you're real doctors. So you can kind of give us the 50,000-foot view and then the on-the-ground view as well, as we said before, the ground is moving. Just perhaps starting with you, Dora, and then handing off to Lori, big picture wise, where do we stand? Where does the nation stand in your view regarding health equity? Are we trending up, down? Are we treading water? Where do we stand from a national picture, Dora?
I think if you take a step back and look to where we were 20 years ago, even longer, when unequal treatment came out by what was then the Institute of Medicine, and the way it tracked the very significant disparities in quality of care, to where we are pre-pandemic, I think that there were still profound inequities particularly for certain groups and in certain conditions, or if it was access, coverage to care. But at the same time, we did see a narrowing and disparities in life expectancy is one example, and certain screening, we saw certainly reduction in disparities. And so even with the work that remained, we had seen, compared to 20 plus years ago, we had seen some improvements. But I would say that, and I'd be curious if Dr. Zephyrin agrees, I think that the pandemic certainly reversed progress in a number of key ways. We were all able to see the profound disparities in who got sick, how well they did, who survived infection with COVID. And in really cases, it just makes us take a step back and think about, for all of our effort focus on addressing inequities and trying to reduce disparities, where were the areas of success? Where are the areas we really need to double down? What are some of the newer models and proposals that we might want to consider and test? And I really think it helped to sharpen the policy community's commitment to really elevating this issue once again, and to really think about how can we dive deeper, what's the various roles and what are the investments that are needed. And so this certainly is an exciting time, I think, to be in policy, particularly for those of us that have been worked in the field of health equity for so long, and also even certainly for those around this new administration and the charge from the White House, from our Administrator Chiquita Brooks-LaSure to our CMS Innovation Center Director Liz Fowler. Everyone is very much aligned that this is a top priority. And to that end, when we released our strategy refresh in October of last year, we released our 2030 vision, and part of it just very bluntly stated to achieve an equitable healthcare system. And also, of our 5 strategic pillars, one of them is focus on advancing health equity. So we are not only integrating it throughout all of our efforts, throughout all of our work, but we're also elevating it as its own pillar to really, again, focus attention and investments in that area.
So it is it's one of 5 pillars for 2030 then. I guess we've got 8 years left and counting, eh? Let's see what we can pull off. I wonder. What do you think, Laura? Do you concur with that? What does the big picture look like to you, and what are the trends like?
Yeah, I definitely can concur with that, as I often do with Dora. I also, COVID has also not only just has unveiled like the deep inequities in our society, right? It's also not only, I think, elevated as a priority, as Dr. Hughes has mentioned, it's also provided insight for those who may not have been aware that just how deep the problems are that we have to solve. And so, so really the question is like, how do we make the impact? What's the right solution? What's the best time? And we can't wait, because while we wait, as you mentioned, Cliff, both, Dora and I are healthcare providers and really started our careers that way. But, when we think about people on the ground, like while we wait, people are losing their lives and getting sicker when they shouldn't. So the time is now, and we have a really exciting policy window. I do want to talk about, we just recently released a health equity scorecard at the Commonwealth Fund, which really, I think, highlighted some really key aspects. I mean, a health equity scorecard really looks at how well healthcare systems are working in every state for people of color, and asking the questions, are people of color having different experiences, for example, than white people within the same healthcare system? And almost always what we found is, yes, there are these inequities. The scorecard really show that in state after state, people of color have worse experiences, worse outcomes, whether we look at outcomes, access, and quality. And what's striking is that we know that now, we already know, and we have data to prove it, that health equity does not exist within any state in the United States, even with those states that have stronger healthcare systems. And so while in some ways it could be really striking to see how deeply entrenched and damaging these inequities are, it's definitely not a surprise. And so we also have to address and understand the root causes. And these inequities have really been in existence for decades. And so it's really important, as we look at the data, as we see these inequities and as we move forward with these interventions, to be able to track and ensure that we're making a positive difference and improving these inequities and actually advancing towards equity.
So it seems as though our recent experience last 2 years, I think we've read a lot about how disparities have widened, but many disparities were revealed that we didn't even realize were there. And of course, your scorecard, Lori, and others have kind of delved into that, just kind of identifying disparities that didn't used to hit our radar. So maybe the problem's been bigger than we thought. Dora, I want to come back to you on the issue of what you're doing at the agencies, your health equity strategy, and maybe from both, again, because you have multiple perspectives, from a system perspective as well as from Medicare, Medicaid beneficiaries perspectives. Tell us more about how the strategy got rolling and where it's headed, please.
Sure. And so as the strategy was developed earlier this year, the CMS Innovation Center, we were very much at an inflection point. We had celebrated our 10-year anniversary. For those that weren't aware, the CMS Innovation Center was created as part of the Affordable Care Act. And so we had finished our 10-year anniversary celebration. There was also around the change in administration and new leadership. And it really made sense to take a step back and think about, what have we accomplished and what have we learned from the past 10 years? And where do we want to go, again, to achieve a health system with equitable outcomes? And through that, we developed a strategy with 5 pillars, which I won't go into, but I'll mention them deeply. One is focusing on the majority or all of our beneficiaries, all of our Medicare beneficiaries, the vast majority of those in Medicaid, and accountable care relationships, advancing health equity, innovation, making sure we're providing the technology and tools and data and supports that providers need to engage in innovation models. And the 4th area, focusing on affordability, both at the systems level and for our beneficiaries directly. And the fifth area, most importantly, certainly is partnerships, understanding that we have to work across centers, work across our agency partners, and frankly, work with many others in the community, particularly those that we haven't necessarily reached out to before, and with the central focus on beneficiaries, of course. Within the Advancing Health Equity pillar, we have four main areas of focus. And the first is really as we are creating new models or revising, modifying models that have at least 3 years left in the pipeline, that we're thinking about how are we embedding health equity? What are the care delivery interventions? How are we recruiting? What's some of the payment considerations? All of that, like how does that help to promote equity? The second area of focus is recruitment of safety net providers, whether that be providers in federally qualified health centers or rural health clinics or behavioral health clinics, the whole range of safety net providers. And we're focused on that in part because we need to increase the number of beneficiaries from underserved populations who are participating in our models. When we took a step back, we realized that because of a variety of factors, we didn't have that many safety net providers. And given that they disproportionately care for underserved populations, the key to getting to more diverse beneficiaries is by increasing the number of safety net providers in our models. The third area, it sounds very basic, but we're really focused on evaluation. And at the end of the 10 years, when we took a look back, we realized that because we weren't specifically asking ourselves, what is the impact of our models on health equity? And many of our models, we don't know actually what impact they've had on access and quality of care for underserved populations. So being very deliberate from the very earliest stages when we're conceptualizing models and starting to develop them, thinking through what are the questions we have to ask to get to a robust evaluation. And then the final area is focusing on strengthening the collection of demographic data as well as data on social needs, SDOH, social determinants of health, increasingly recognizing that having greater data availability is key, both to monitor and evaluate our models, and of course, certainly to inform design. So those are the four areas that we're focused on. We have a team internally that's very much focused on health equity, but also, Cliff, we are increasingly working in a coordinated fashion with our colleagues in the Medicaid Center and the Medicare Center, certainly in our Center for Clinical Standards and Quality. So I also think that as part of our CMS administrator's charge, we are not only focused very deliberately on what each of us are doing in our individual centers, but how can we work across centers in a harmonized fashion. And I certainly would have to give a shout out to the CMS Office of Minority Health, who is very much helping to coordinate these efforts as well. So it's an exciting time at CMS. We have very tangible efforts that we're working on, and that certainly you will be hearing more about in the days ahead.
So with regard to health equity, then, it's about the new models, safety net providers, evaluation, and the demographics, including going after SDOH, and to pull off those four aspects under equity, you've got to make all these partnerships work, as it were. You mentioned affordability just a moment before that. Can you say a little bit more about the tie-in of affordability and what you're trying to make work with health equity? Just briefly, Dora.
So the affordability pillar, I think, don't want to create news here or lean forward too much, but certainly we are. But some of our current models, as you know, for example, our Part D senior savings model focusing on providing insulin at a more affordable price for our beneficiaries. That is an example of one of our efforts to really think about costs of care that directly affects beneficiaries. Are there other things that we can do to address costs for that? It's meaningful directly to beneficiaries, as well as, and certainly, of course, always thinking about broader system costs, even as part of the charge of the center as for us to think about ways that we could reduce healthcare costs while maintaining or improving quality. So it is part of like the very statutory charge, our mission for being in existence. But we're thinking about it at the overarching systems level, but also what does that mean exactly for our beneficiaries?
Great. Well, thanks. If you can make a dent in that insulin challenge, that'd be plain right there, Dora. Good gosh, it's a big issue. Lori, I wonder if you could do something similarly vis-a-vis Commonwealth's portfolio. And I know one thing might be useful for everyone to hear is, I know you've got some state work as well, state level and state comparisons that might shed additional light. Lori?
Well, I talked a little bit about the health equity scorecard, and happy to go into that in a little more detail. I think, I mean, I can step back a little bit and just talk about, the goal of our program is to eliminate unequal treatment, experience, and outcomes in health and healthcare for people of color by reducing systemic racism in healthcare policy and practice. We have 3 key focus areas that are focused on system, policy, and culture change. And so, for example, really in terms of healthcare delivery systems, for example, where supporting work such as Out of Rush, for example, and their racial equity scorecard that they're rolling out across healthcare systems in Illinois, and hopefully there'll be an opportunity to explore expanding that nationally, supporting work with IHI around their Pursuing Health Equity initiative to really bring together the whole ecosystem of healthcare and really talk and understand measurement, for example, focused in on health equity. So not bringing together delivery systems, payers, providers, et cetera, as well. And also, really thinking about what tools can be for providers or people within healthcare systems that are focusing in on health equity. And so we're actually supporting some work around doing a health equity survey of those that are leading health equity work within healthcare systems. As we know, there's just variation potentially within healthcare systems in terms of budget, integration into strategy, integration into quality and measurement, quality and safety, and equity in that integration, which is all really important in terms of advancing health equity on the systems level. In the policy aspect, definitely understanding equity impact of policies. We do know the role of policies in contributing, promoting, entrenching systemic racism and inequities. There's also the role of policies in dismantling that. And there's really an importance to be able to measure that impact as well. How do you know policies are actually shrinking disparities and advancing equity? And that's an area that we're also very focused on as well. The federal policy opportunities, Dr. Hughes talked about the work that she's leading and is happening at CMMI. But as we think about the federal policy opportunities are huge for really advancing collection of data that can promote health equity, of having availability of race and ethnicity data, and it's really important to understand not only the challenges of that, the barriers, but also the opportunities to intervene, to be able to have data so that we could better understand where the inequities are, and thus are the interventions working. We also have work around that we're supporting around value-based payment and payment opportunities as well. Some of that is focusing on maternal health, for example. What are maternal health? We all know about the rising rates of maternal mortality in the United States and the significant disparities. And so what are policy opportunities to address that in a meaningful way? I think payment is a powerful opportunity to address that. We have a really a great understanding and evidence around what works, for example, around maternal health and what high value care is. And so what are opportunities to support payment models that can actually drive that high value care? And I can talk a little bit more about that later. We also have work that we've supported with states and primary health care, for example. So we've supported work and partnered with the Center for Healthcare Strategies and working with states that are focusing in on Medicaid managed care and really thinking about how can, through Medicaid managed care, one can promote equity through primary health care. I mean, primary health, everyone should have access to primary health care and a primary health care provider, significant opportunity to drive down inequities by improving access to primary health care. And so how can we promote inclusion of equity-related provisions, for example, in Medicaid managed care contracts? And so this work is really providing technical assistance to a handful of states, who've identified additional strategies that Medicaid agencies can use, for example, to help promote managed care organizations to promote health equity. So that's some of the work that we're focusing in on. I think the piece of the work that I didn't get into is the importance of the data collection aspect, and I'm happy to talk about that a little later on as well.
I may come back to you on the data. Now, you mentioned 3 areas: system, policy, and cultural change. So, a semi-sensitive political question here. How optimistic are you these days about achieving the cultural change that would bring about a meaningful gain out of proposed policies? I mean, we can talk about policies all day long, but I might be a little concerned about our ability to pull off cultural change these days. Do you have a view on that you might want to share?
Well, I mean, I think that's a great question. I mean, I'm a, half glass full type person. So, any question you throw at me, I try to put an optimistic lens on it. I mean, I do think when we're talking about health equity, the culture change aspect is critical, right? If we're ever going to have long-term change, right? And part of shifting culture is to be able to have policies that demand accountability and help promote and support cultural change to advance health equity. And so I am really a proponent of really helping to drive systems change and policy change and payment model change to help provide that accountability that really creates those incentives around culture change. I think probably the broader sort of maybe gist of your question is what it takes to promote culture change, and I think that's that is a heavy lift, and that's not something that happens overnight, and that's something that requires not only persistent conversation and bringing the right people into organizations to really address inequities and biases and implicit or explicit. And it's really important to incorporate that alongside of policy and systems change.
Well, I appreciate that, because those 3 elements you mentioned, it seems like we need culture change to enable better policies that would result in system change. And so
I'd see the arrow as going back sort of 2 ways.
Got it. Okay. And a follow-up question, you mentioned equity provisions in managed Medicaid. Mm-hmm. Can you tell us what's the lever or the carrot or the stick in managed Medicaid that narrows disparities or enables equity? Can you just give a thought or two on that to us?
Sure. And so this work that we've been supporting has been focused on primary healthcare innovation, and actually for Center for Healthcare Strategies, there's a primary healthcare innovation toolkit that has a racial equity module, health equity module in there as well. But in terms of levers, so for example, are there opportunities for Medicaid and when contracting with Medicaid managed care to incorporate requirements around tracking disparities, measuring disparities, having data on key quality indicators by real and SOGI data, for example. And so I think opportunities like that are really important. Are there opportunities to integrate, for example, addressing social determinants of health / drivers of health, integrating community into payment models, for example? Are there opportunities to be able to actually track outcomes? So, for example, one state example is, I guess I can give the example of Louisiana. For example, they're thinking of updating value-based reporting requirements, right? So that strategic plan submitted by MCOs will include a review of health equity activities, right? So that's one example. Or having a health equity action team thinking about how to integrate health equity into ongoing primary care activities, like building data capacity to inform health equity in Medicaid, or using explicit language to be able to acknowledge or provide training around addressing bias and racism. So partnering with communities, for example, to advance health equity at state and local levels. I think there's just powerful levers at the local level in Medicaid, which is serving, underserved people, to really ensure that the quality of care and the equity of care that's being provided is there.
So I'm glad you did that, because we've all been talking about these issues, some for days, some for months, and some for decades. But you're talking about building these provisions into health plans, basically, managed Medicaid plans. It's reporting, accountability, and further action, it sounds like. So that's very encouraging.
And I think when you talk about value-based payment, right? I mean, when you talk about VBID or value-based payment, I mean, you can't really provide value without providing equity. So that's not distinct from, the work that we're talking about today and what this conference is about, I think.
Absolutely. Thank you very much. Well, Dora, I could ask you to reflect on the several points just made or requested, but you did mention some aspects about data a few moments ago, and I was wondering if you could kind of get into what sort of data you're collecting and organizing and synthesizing to support your programmatic efforts. But if you wanted to weigh in on any of the above issues as well, you may do so as you wish. But I do want to get into data if you don't mind.
Oh, sure. No, again, as we think at Innovation Center and certainly across CMS, having greater availability of data, demographic data, as well as social risk and SDOH data is absolutely critical. And so as part of that, we face two, in some ways, we're working in parallel paths. I mean, the very first is acknowledging that although we have tremendous amounts of data internally to CMS, many of the, particularly Medicaid data, is not always the best quality. There's a number of issues that makes it less reliable for some of the activities we want to support. So in the here, if we look at the here and the now, we are certainly scraping to see all the data that we have internally. We are also reaching outside of CMS to some of our agency partners to see what data they may have. For example, in the Department of Housing and Urban Development, what data do they have on housing and security, and could we match that with some of our programs? But we're also looking at other tools such as imputation of data, of course, and looking at other proxies. For example, in some cases, we can use that as a proxy for low income, our beneficiaries that are eligible for Medicare and Medicaid. We call them dual eligibles, as one example. Or those that in the VBID model space, we target beneficiaries who qualify for the low income subsidies. So we're both imputing, we're using proxies, we're using the data that we do have in the current time right now to start to better monitor and evaluate our work that's underway. But that being said, we're also on the parallel track thinking about what can we do for the new models that will be rolling out 1, 2, 3 year period. What are some of the requirements that we might put in place for participants to collect data, to ask their patients, so that we can have more patient-reported data, which is in many cases they consider the gold standard by most, I would say. And so, but in order for us to ask providers to collect this data, to ask this data from patients, we also have to think about what tools how can we help? And so we are creating screening questionnaires, for example, putting some of our questionnaires in FHIR-based standards, creating the APIs, trying to think about how can we, what mechanisms are needed for some providers who don't have super sophisticated EHRs that maybe they need to dump the information by way of an Excel file. okay, so but we need to be able to accept it and store it, and all of those very practical operational issues are that are underway as well. So doing what we can do right now, looking towards the future, how can we facilitate greater data collection, and not just for race and ethnicity, but across those who may live in rural areas, or those with disabilities, or those defined by sexual orientation or gender identity. We just want to make sure that we're capturing the full range of beneficiaries who are in our program, so that we understand the access and quality of care and experience with care that they're receiving. And so, so that I would also, just as an example though, of where we're moving, I think 2 or 3 weeks ago, we released the ACO REACH model, or Realizing Equity, Access, and Community Health REACH model. And as part of that, there are 4 equity provisions that I might highlight. And one is requiring demographic data collection for those that participate in that model. That is a requirement. The second is that we will ask our model participants to prepare health equity plans to make sure that they know the populations they're serving, to identify any disparities that may be present, and to tell us how they intend to address these disparities. The third area, very important, is for those model participants that are serving a disproportionate number of underserved beneficiaries, they will receive a payment adjustment, recognizing that in many cases, caring for these potentially more medically and socially complex patients will require a higher level of resources. And how can we do that? And then the fourth area, there is a new benefit as part of the model, and nurse benefits, so that again, understanding that we trying to care and coordinate and manage care, having additional options such as the nurse benefit enhancement could be one such way. It could be useful, certainly, to the providers participating in the model. So, and also I said 4, but I'll mention one more, 5. When we're looking at the applications, when we're looking at those that want to join our models, we do want to know, what has your experience been like? What's your track record in caring for underserved populations? We will be seeking to add that to as part of our review, along with all the other factors that are certainly very important as well. Join in ways to think about, how are we encouraging, again, safety net providers and others who might be newer to the ACO space to join us as we work to promote equity.
Well, having heard you run through that, Dr. Hughes, I'd find it daunting to have to look at your computer screen on a Monday morning. Like, where do you start? Something that really strikes me is the matter of terminology and vocabulary. I know I'm not terribly knowledgeable about this, but I know that categories of race and ethnicity appearing on various forms can be confusing to people and sometimes counterintuitive. And then you mentioned sexual orientation and gender identity. Do we have the terms and the check boxes to accommodate that? It seems like we're going to have some sort of transformation to even put the cells in to capture the data to which you referred, right?
It is, and that is a very important issue. There are standards on the race and ethnicity side, but for some of these other categories, standards are in development. And for us, for our models, we're partnering, looking to the Office of National Coordinator, ONC, their U.S. Core Data Interoperability, CDI version 2, starting to include some of these other demographics and their standards, as well as version 3. These are standards, again, voluntary, and they are, but still they will be increasingly adopted by the software and EHR and other vendors and others who are looking to see where can we peg our efforts, so that again, it's important that all the different providers aren't doing their own thing or using their own terms or their own standards. You know, that's a very important point that you're making there. And so I think, again, where we are right now is can be fairly rudimentary, but hopefully in the next coming years, particularly, very importantly, where Dr. Zephyr is talking about, we have to promote the cultural change and explain why we're doing this and why it's important and all of that. But at the same time, as we move to require it, to put greater requirements and incentives, that will also help to drive cultural change in a different type of way. We wanted to make this, again, a very systematic and just a part of what we do as providers, as opposed to something extra that's a burden and that must be added on. Although at the same time, we're acknowledging as we get to that state, there's a lot of different ways that we'll need to assist till we get to that point.
But it's impressive that you're building this into your models. You
Yes.
wanted to have a new model with us. You got to build in all these components. I've heard you say they've got to have health equity plans. Heard you mention at least one carrot, which was the payment adjustments along the way, which is good. So again, not just talking about it, but building it into the models, as well as setting up, revising, whether it's FHIR or anything else, APIs, whatever, coming from a technical standpoint, more robust systems to actually track this stuff, evaluate, and provide feedback. I want to ask first Lori and then back to you, Dora, on this another sensitive issue, and it's a form of garbage in, garbage out, as they say in the old days, and that is, you both talked about collecting data and making the system better and so forth. We've seen instances of unintended racial disparities in algorithms, racial bias, unintended instances of that where biased data collection goes through algorithms or other systems and spits out an answer that is also biased. And I'm just wondering, since you're both so in tune with data and evaluation, if you have any reflections or thoughts on that. Lori first, and then perhaps Dora, if you don't mind.
Sure. Yeah, that's a very important question. I think part of it goes back to why do we need this data to begin with, and what are we using it for? I think is really a really important consideration. I mean, I think a good example of algorithms can be thinking through an algorithm formula is used for kidney disease, for example, the EGFR, estimated glomerular filtration rate, high level, like it can help look at function of the kidney, right? And so that initially included race in it, but looking at data, it showed by including race in that algorithm, then less Black people, for example, were referred for kidney transplant. And so, so there's a number of other formulas, whether you're talking about the VBAC formula, vaginal birth after cesarean formula, that include race, which is a social construct, into these formulas, which can result in biased information. Now, how it was determined that it resulted in negative and intended consequences is that people studied, evaluated, and realized that that there were less people being referred for high value interventions. And so I think it's important to be aware. And part of that required essentially, recommendations around removing race from, for example, the EGFR algorithms. And there's a whole effort going on about that, supported by National Society. So I think that's a good example. And so as we think about, I think your question was probably focused on AI, and using data around artificial intelligence. The data that we put in is sort of based on our current societal context. And so we always have to have questions. We have to have diverse teams looking at it. We have to look at our outcomes and ask questions as to, are these the outcomes that we're expecting? Is there any potential bias in the outcomes? So I think that's an important conversation. The other conversation is, like our data currently, we need to better understand where the inequities are. And so we do need data addressing race and ethnicity and sexual orientation and gender. So we need that data as well, because otherwise, one, we know we measure what we value, and two, you can operate blind by not knowing where the inequities are and assuming there aren't any inequities there as well. So I think a balanced approach is important, and an awareness and understanding of what you're using the data for, and then being able to look at the impacts and being able to interpret them in a meaningful way.
Thanks on that very much, Dr. Zephyrin. Dr. Hughes, do you want to weigh in on that just a bit, since you're so data oriented and you're trying to pull so many data sources?
Yeah, sure. And I'll be brief, recognizing our time is short, but earlier this year at the CMS Innovation Center, a number of my colleagues, we conducted the implicit algorithmic bias pilot project, and it really was seeking to, we're hearing theoretically about the concerns. How is that translating to our models, and could there be problems? And as one example, we looked at one of our kidney models to see if the race-adjusted GFR tool that Dr. Zephyrin mentioned, how could that be a problem for our model, as one example? And we found that because that determined which beneficiaries could join our models, that certainly could have been an unfortunate limiting factor in terms of beneficiaries not being able to take advantage of some of the transformational benefits of the kidney model. We also looked at one of our heart disease models. We also looked at one of our joint replacement models. Again, to think about, are there ways that we have inadvertently included bias in our models, and also to then think about what are the steps we need to take moving forward to make sure that we're systematically looking to see at every point where bias might be introduced, and in terms of the assumptions built into the models, the data that's collected, the tools, the measures that we're using, that again could be having a negative influence in terms of who's able to access our models and what their outcomes may be. So it's an important area of work, and one that certainly you'll hear more about in the days ahead from our work as well.
So something I'm taking from your comment then is, it's not that you're going to go back in and try to clean up a mess with data, but prospectively you're looking at your models and algorithms and so forth to try to make sure that bias is not designed into them. Does that sound right?
Yes,
Okay.
but I wouldn't say that even from the pilot study, I wouldn't say we found a mess,
Okay.
but we did find areas that potentially we would want to be more attentive to moving forward.
Got
And
it.
as an example, in the kidney space, recognizing where things have gone using eGFR, that's an easy fix for us in terms of, all right, this is a change that we need to make. So
Easy fix, but a big problem. Yeah.
Yeah.
Highly notable. Well, we only have a few minutes left, and maybe I will start again with you, Dr. Hughes, on this, and that is looking at how we lower barriers to high value care, lowering barriers to high value care. If you look back at the things that you've just been discussing in this session, or anything else you haven't mentioned, do you have one sort of shining star on the horizon that you like to achieve, whether programmatically or otherwise, that you think would really knock down a barrier to accessing high value care for the beneficiary of populations for whom you're responsible?
Sure, and I think there could be many examples that my colleagues could share, but one I think specific to the VBID model is an example when we had the authority to target the benefits of the VBID model to the underserved populations, as defined by those that were eligible for low-income subsidy. That shift has been fairly recent. We don't have full data and outcomes, but already we're seeing signs that that is really being very deliberate and targeted in our focus, is providing benefit to the populations that would benefit most. And that is what's critical to getting to equity and access and equity outcomes. And being able to wrap around that with thinking about what are some of the learnings. We have a health equity incubator that will be launching soon. How also can we help the plans provide the information that they need, understand what benefits they may want to provide, whether that's food assistance is one example. But I really think just being able to focus very carefully and deliberate is critically important. And that is how one way you can address the barriers to what we would consider high value care.
And most appreciated that you mentioned that. And it reminds me and others that you mentioned before HUD, you just talked about food insecurity and so forth. Lowering those barriers is kind of a larger problem set or solution set, I should say, given what I've learned from both of you thus far. And so just a couple minutes left, Dr. Zephyrin, could you answer the same question insofar as what's your shining star for lowering barriers to high value care?
So I'll twist the question a little bit in terms of where I think there's significant opportunities.
Okay.
And I think I'll highlight maternal health as a significant opportunity in terms of promoting high value care in maternal health. I mean, we see the significant inequities and the rising rates of maternal mortality and morbidity just based on recent data. And so when we think about like promoting value and promoting better outcomes and better health, I think there's a great opportunity to do that in maternal health. We know, for example, team-based care, having midwives, doulas, home visiting models, like integrating that into a value-based payment model and value-based design, I think would be really critical. The data aspect, being able to disaggregate data to better understand and track where the inequities exist. As we think about Medicaid postpartum extension, that provides a really important opportunity, and just more broadly incorporating that 1 year postpartum into the value-based payment model lens around maternal health, really focusing in on key quality measures that address morbidity in the hospital and even or outside of the hospital and beyond. I mean, we have a lot of great evidence, and I think just in terms of a policy window, there's just a significant opportunity to prioritize equity and use maternal health equity as a way we can really drive down significant disparities.
Well, the maternal health is almost like a system-wide tracer. If we could close the gap in maternal health, we know that, which would be great, we'd be closing a lot of other related gaps as well. A lot of domino effects on that too. So thank you very much for that answer. So we're very close to the top of the hour. With regard to a VBID summit on enhancing health equity, you can't do better than our two keynoters here. Great thanks to Dr. Dora Hughes and Dr. Lori Zephyrin, representing the latter, the nonprofit private sector, and the former, the public sector, and both are real doctors too. And I really appreciate that you've kind of brought that whole, you gave us the 100,000-foot view and you brought us the on the ground view. I'm just so impressed by how much work you all have done and what you need to do. Like I said, when you turn on that computer screen on Monday mornings or whatever it is, Sunday nights, whatever it is, there's a lot to do. But when it comes to closing disparities, using data, using advanced analytics, building equity into systems, there's a lot to be accomplished there. And we're glad to have leaders like you. Thank you, Dora Hughes. Thank you, Lori Zephyrin. Great to have you today.
Thank you
so much.
All right.
Bye.
Well, gosh, what a great springboard to move into our next session. This session, session 2, is on expanding the role of VBID by public and private payers. And the expansion there is going to be a key aspect of it. With our 3 speakers today, Mary Beth Donahue, Joy Cameron, and Laura McWright, we're going to look at several areas, some of which are, what do you actually mean by supplemental benefits? What are those? Tell us about how vulnerable populations might be benefiting from these, including Medicare Advantage and other supplemental benefits efforts. How do we maybe think about expanding these supplemental benefits to achieve greater effects, and maybe even getting to the data and the analytics to pull this off? So as before, we're going to ask each of our speakers to introduce themselves. Mary Beth, if you could start out, tell us the who, where, and how it is your job places you on a panel about expanding the role of VBID by public and private payers. Mary Beth.
Thanks so much, Cliff, and I really appreciate the opportunity to present today and to be here with Joy and Lori. And as far as my background, as you mentioned, President and CEO of the Better Medicare Alliance, and I appreciate your conference convening, focusing on enhancing health equity. And we at the Better Medicare Alliance, as we represent 170 plans and over 600,000 beneficiaries, we're solely focused on strengthening and protecting Medicare Advantage for those seniors, and one of those areas is in supplemental benefits. So do you want me to just go ahead and jump right into speaking about what's meant by supplemental benefits?
We're going to come back to that. I want to make sure our own two guests introduce themselves, but that's going to be top of line. So do be queued up for that. Thank you.
Okay, great. Did not want to get ahead of you. But I guess I just want to, as part of that introduction, just be able to give an example, of the flexibility in Medicare Advantage in the VBID model, which is one way in which MA is able to offer those supplemental benefits and meet the social needs of seniors, including food and nutrition. So I look forward to diving into that later into the questioning.
Perfect. Thanks very much, Mary Beth. Let's go over to Joy Cameron. Joy?
Good afternoon, everybody. My name is Joy Cameron. I'm an AVP of Public Policy here at Humana, which means I'm inside the Corporate Affairs Office, which is your trade association work. We are members of the Better Medicare Alliance, but also the work we do with our friends at CMS and HHS, as well as Congress and other branches of the administration. So that's where I sit, and as most of you are aware, Humana is a big participant in a lot of the CMMI and VBID demonstrations.
Great, and we're going to come back to those as well. Thanks very much, Joy. Let's go over to Lori McWright. Lori? You may be on mute still, not sure.
Can you hear me now?
Yes.
Great, okay. Well, good afternoon, Cliff, and thank you so much to the VBID Center for inviting me here today. I'm Lori McWright, and I'm the Deputy Director of the Seamless Care Models Group within the CMS Innovation Center. And within my portfolio, I get the pleasure of overseeing the value-based insurance design model, and really happy to be here to build on what Dr. Hughes described in the VBID model, and talk with you all about kind of what we're doing now, what we've seen, and what we are excited about for the future. And certainly health equity is no small part of that. And so thank you.
Great to have you on. Thank you so much. So you've met our three speakers here today. And as Mary Beth suggested, one of the things we want to go back to is, what do we actually mean by the term supplemental benefits? Mary Beth, could you kind of get us started, then we'll go next to Lori on that? What's in that kind of market basket of supplemental benefits?
Sure, thank you, Cliff. And this time I'll jump in with the video on. Apologies, I had a little technical issue with that before, but I was not going to hide from you for the whole panel.
Okay.
In the Medicare Advantage context, supplemental benefits are one way that MA plans provide additional value to beneficiaries, especially those beneficiaries with chronic health conditions. And they also provide financial protection and health security to beneficiaries, including coverage for services and care not covered by traditional fee-for-service. It's also able to provide additional supplemental benefits due to the innovative care model, which provides care more efficiently in some cases than fee-for-service. And because of those efficiencies and cost savings, MA is able to provide those additional benefits and ultimately reduce patients' out-of-pocket costs. And just one fact that I think is really helpful to paint the picture on those savings is research shown that MA beneficiaries can save an average of $1,640 a year compared to fee-for-service, while still receiving those expanded benefits such as vision, hearing, dental, and wellness that we hear so much about.
Sounds like real money. And Mary Beth, you still on?
Yes.
Oh, there she is. Okay, good. There she is. I thought you froze for a second. Lori,
I
just
might
want
have
to.
frozen, but I'm here.
Okay, good, good. You're back. You're unfrozen. Yes. Lori, tell us a little bit more from your standpoint about what comprise supplemental benefits and how they kind of might augment or complement traditional healthcare benefits.
Yeah, that's a great question. I mean, I think from a VBID perspective, you know, the supplemental benefits themselves aren't always that different than what you see in the traditional Medicare Advantage program. I think it's the targeting of populations that actually is unique to the VBID model, to be able to target by chronic condition and not sort of meet a number of specific criteria. And as Dr. Hughes talked about, the targeting by income, socioeconomic status, the low-income subsidy marker for Part D is the proxy. And I think that is potentially needle moving for beneficiaries to, you know, improve outcomes and help sustain the Medicare Trust Fund. You know, we're seeing all kinds of certainly interesting benefits, things like healthy food, grocery cards, non-emergency medical transportation, I guess combinations of benefits through packages where enrollees can choose through a menu of supplemental benefits. You know, it might range from $500 annual allowance for healthy meals, or it could be $500 a year to as an allowance, I guess, to choose from dental, vision, hearing benefits. So, you know, they really range, but I think what we've seen is the real focus on the targeting and meeting some of the social determinants of health for the underserved populations that is what we're most excited about. You know, VBID started out as sort of a much smaller in scope model, you know, where we were testing a few chronic conditions in a few states, and it's really evolved into a much broader scale test of, you know, alternative sort of benefit package, not only with the chronic conditions, but, you know, via the income marker as well. And, you know, I think that just has huge possibilities to be able to address, you know, enrollees, not only their general health, but I guess maybe from a more holistic vantage point, which would include like their behavioral, their physical and social drivers of health. And, you know, we certainly are excited to, you know, to be collecting more specific data around, you know, health equities that can perhaps address some of the gaps in understanding here. You know, we certainly know enrollment is up in Medicare Advantage, and we've seen the interest in our model, and to be able to sort of develop more specific insights around the supplemental benefits, the rewards and incentives programs as well. You know, understand who's using them and their impact is definitely exciting. And, you know, overall, and I think Mary Beth was speaking to this, you know, to really get a sense of what's the value quotient. I mean, it is the VBID model, right? And so we want to make sure that we really understand the value of the benefits for the beneficiaries. So, yeah, so I'll stop with that.
So, Lori, but when we consider, I'll use that term market basket again. Well, you talked about a menu, I guess. The stuff on the menu can include food, transportation, not necessarily medical, cash, I guess. What else? What are the kinds of things that would be listed in a typical menu, if I could phrase it that way?
Yeah, I mean, I think, you know, it could be sort of either primarily health related or non-health related benefits. So that could, you know, that could include things like transportation, or it could include the an air conditioner, say for an asthmatic population.
Really?
it could include the things that would support healthy living, and not necessarily be considered a medical benefit. Yeah.
So food
And actually, can I make one other comment? The cash benefit is available through 2022, but will not be directly available from 23 and on.
Aha. So, which could be considered further in the future, which might not be a bad idea, but such disparate things as food, air conditioning, transportation, and what had been the case, cash and so forth. I'm going to ask, and I'm going to come back to Lori and Mary Beth on the following question, which is, how do you go from traditional health benefits from a contractual or financial standpoint to stuff like food? In other words, we have laws that say this is what healthcare is. And so are there any hurdles or barriers to kind of start pulling in other things like air conditioners into the traditional health plan? Joy Cameron, just curious, just bouncing off of what we heard Mary Beth and Lori said, from your standpoint at Humana, when and how did you start thinking about supplemental benefits?
I think that there's been a number of initiatives at Humana where we've been looking at our bold goal populations, which is serving those with social determinant of health issues. But I think it's also just getting to know our members well and seeing where they are and seeing, to kind of pick up a little bit what Mary Beth and Laurie were talking about. If you live in at the top of Maine, you may not need an air conditioner, but if you're in Alabama and it's August and you are homebound, this could be an opportunity to bring you comfort. And what it does is it does impact health. Absolutely. It's not just your quote unquote comfort, but you're becoming dehydrated, possibly disoriented. There could be potential for falls, emergency room. So I think what's great about these supplemental benefits is it moves us from that very traditional, heavy regulated space. And with the optionality and flexibility that exists in the ACA, kind of pulling that forward and saying, here are ways for us to get in front of some of these events that we don't want to see occur to either our members or our clients, if you're a provider, et cetera. How can we help them? Let's meet them in the place where they are, whether that's food because they're facing some food insecurity issues, whether that's climate control issues within their home, whether that is transportation where there are issues with them getting to these primary care appointments. Let's not wait until it's an ambulance and an emergency department. Let's take the easier route of safe, secure transport to a primary care physician. Let's get in front of the never events, so to speak. And I think that's really what these supplemental benefits are all about. It's that step before it all qualifies as emergency healthcare.
Joy, was that a hard case to make internally at Humana? And is it viewed within the company as a competitive benefit offering? In other words, you look better if you offer these things.
Well, I dislike the term I look better because we offer these benefits. I think it's our members are inclined to stay with us because we're better able to serve them. So if we just did straight Medicare and did not explore these areas, we would have difficulty competing for those that were thinking about the fitness and wellness and hearing, whether it's dental, vision, that sort of thing, or even food. Like let's make sure we are matching our population and providing them what they need to stay healthy, because it behooves us for our members to stay healthy and happy, right? So I think that's the goal of all of us in healthcare, is trying to meet our members where they are and provide them what services we can so that they're able to live better, healthier lives. I think we all live under the metric of healthy days at home. So the best way to get it, healthy days at home, is provide the services before they need to go to the hospital.
So in pursuit of healthy days at home, you actually consult with your membership. And there is variability from Alabama to Maine, as it were, insofar as what those benefits comprise, correct?
Well, and the ways that we consult with our membership may not feel like an interview where I call up Miss Jane and I say, Miss Jane, what's troubling you? It could be, one of our case managers reaching out because, hey, I saw that you haven't had a primary care visit this year. It could be an in-home wellness assessment where we have a longer conversation about what's going on. But in that moment too, also have the ability to have eyes on and see what's going on in the home in areas where we may be better able to support them. So it's a collaborative and ongoing conversation. It's not a survey sent once to your membership about, if the world was your oyster, what would you like to have?
Got it. So Lori, go ahead, Mary Beth, on that. Sure,
Well,
Mary Beth.
I was just going to highlight, to what Joy was responding to as far as meeting the needs of the population and also some of the benefits that Lori was speaking to. In just thinking about the Medicare Advantage population, you are looking at low and modest income individuals. And so in those cases, it's, again, Joy was sort of saying, it's not what looks good, it's what do we need to do to meet the needs of those patients. And when you have a population where more than half are living below 200% of the poverty line, and then we also have duals where in MA, duals in Medicare Advantage has grown by over 125% since 2013. It's, well, what are their challenges? And then it gets to they're in communities where they have social isolation, there's nutrition issues, transportation issues, and then you're also dealing with issues, communities of color, where 53% of Latino beneficiaries are in MA and almost 49% of Black beneficiaries. And so it's looking at what are the other sort of non-health benefits that they need. And that's, what's trying to be addressed, whether it's nutrition or transportation, or we've talked about, addressing structural improvements to the home, which may sound glorified, but when you have someone go into the home and they're identifying a loose floorboard, addressing that could then avoid, an eventual, broken hip of a senior that could then be a downward spiral of other issues.
Cliff, you're on mute.
Hey, Cliff, you're on mute.
Was doubled there. This brings the issue to the question I started to raise earlier, which is, and I'll ask this of Lori, and then I don't know if Mary Beth may want to follow up yet again on this, is if you think about food, climate control, transportation, and home improvement, these weren't like written into the Medicare law in 1960, in the mid 1960s, right? So from a kind of a policy standpoint, how do you get these into the program, Lori? And maybe we're not done yet. Maybe we're going to go beyond food, climate control, transportation, and home improvement. But policy-wise, how do you make these things happen, Lori?
Yeah, that's a really, really good question. And so, really the Congress, I guess you would say, really recognized the importance that good health was really beyond just the medical care, and that a beneficiary, all people really need sort of broader social supports to thrive. And so actually, I believe it was in 2018, they actually amended the Social Security Act, so the Medicare statute, to expand the types of supplemental benefits that can be offered through Medicare Advantage plans. So not just VBID, but overall the Medicare Advantage plans, to include these benefits we've been talking about that we would call are not primarily health related. So that would be your air conditioners, your potentially your respite care, your food, transportation, housing. I think where we have the sort of leverage in the VBID space is the targeting and the flexibility for plans to offer these benefits not to the general MA population, but looking at lower income beneficiaries. And it might be really expensive to provide all of these benefits for the whole enrolled population. But if you said, there's a certain set of folks that could really profit from air conditioners who have chronic, cardiovascular disease, or those, that would potentially not be eating healthy and are, sadly diagnosed with diabetes or other, conditions. That's where, looking at the advantages of the targeting mechanism and really understanding outcomes, utilization, who's uptaking, and then what are the outcomes, and are there differences between general uptake and different subpopulations, by color, by ethnicity. And we're really looking forward to understanding better, the impact of the targeting. But the actual benefit of being able to offer non-primarily health-related benefits is available throughout the MA program.
So to the extent that VBID and other kind of newish models have discretion in program design, you can use them as a way to explore innovations in, for example, supplemental benefits, with perhaps the hope someday that those benefits could be extended beyond the models, or am I taking that too far, Lori?
We think about this on a regular basis. Is what's our end game? And I think first is what I described, probably what value are these supplemental benefits offering, and to whom, and in a really base way, are the dollars, the rebate dollars applied to the supplemental benefits, are they good value for the beneficiaries and the Medicare program overall? And what could we learn at a higher level? Are there efficiencies or value effectiveness related to one benefit or a set of benefits, and how might we think about applying that into the program? And that's kind of post evaluation, but thinking at a large level, would you consider, supplemental benefits are designed, by our plan partners. So it's not, it's that return on investment. It's a business decision, as you described, but might there be parameters around offerings based on our evaluation and the results, that it makes sense to ensure that a set of benefits or a basket of benefits were offered together, or that before you offered one set of benefits, you would be required to offer another. We're way, infancy stage to that, but that kind of thinking is on the horizon, I'd say.
Very helpful. So back to Mary Beth on this. Mary Beth, just interested, I know you've got a follow-up comment, but are you seeing any other sort of creativity, Mary Beth, in the community insofar as offering these kinds of supplemental benefits?
Well, I really value the opportunity to follow on Lori about the need to learn more, but
Yes.
And I think at the basis of this, and gives that opportunity to be creative, is that research shows that 99% of Medicare Advantage plans offer supplemental benefits, but at the same time, only half of Medicare enrollees know of the option to enroll in Medicare Advantage. So there's a real opportunity there that if more seniors know of the opportunity to choose Medicare Advantage, then how they, if they chose it, the increase in being able to have access to these benefits we're talking about. At the same time, totally agree that we have so many best practices that are models for growth of additional supplemental benefits. We still need to, and appreciate Lori highlighting this, and it's in the conversations that we have with the CMS officials about just doing what we can to gather more data on utilization and other research. And Joy can speak to that better than I can. But the plans are there offering the benefit, and so to bring more awareness of the benefit of Medicare Advantage to those seniors who don't know it exists, I think would really increase some of these health outcomes that we're already seeing in those MA beneficiaries.
Yeah,
And I guess the other
wanna
point I would make when you pose the question, Cliff, is just the existence of partnerships throughout the country around supplemental benefits. And, you know, one of the things I'm so blessed in leading BMA is our 170 allies and representing the MA community of community organizations, aging organizations, providers, plans, and fortunate to have Humana be one of them and leading in this space. But there's so many partnerships on the ground that have emerged between plans and community benefit organizations, and the innovation and experimentation they're doing that creates these unique benefits that we're talking about even beyond nutrition and transportation.
So are there sources of creativity, Mary Beth, from the environment, from people in your community that they're saying that we can actually expand these?
Sure. I mean, I think there's, you know, several examples. I mean, I think people are familiar with PAPA, which is an organization that addresses social isolation in home, and they're sort of a new category of one of our members, and they provide companionship and assistance from what they call PAPA Pals. And, you know, they go into seniors' home, and what they do is they vet companions who can help seniors in day-to-day tasks, whether or not it's helping with groceries, household needs, technology needs. And, you know, that's sort of an example of one of those non-health benefits that Lori was speaking to. You know, and then obviously transportation to doctors' offices. You know, you then have, we talk about Meals on Wheels, you know, the national organization that has so many different local chapters, and the community partnering that they're doing with plans to provide, you know, bringing food to seniors. So those are just a couple examples where they've been created. And I think, you know, there's so much more creativity that happens when organizations work with others, just because when you look at the needs of seniors, you're never addressing one issue, whether or not it's chronic conditions or balancing into other non-health needs.
Yeah.
Hey,
Go ahead. Thank you, Mary Beth.
I just
Lori?
want to jump in and echo something that Mary Beth was talking about, because I think it's huge. 2 points. One is that I think the Benny engagement strategies is untapped potential there in the sense, and I think part of what VBID has offered, and Joy, you can speak to this for sure, is really learning to how to engage beneficiaries and the sort of strategy element of what works for different populations. And then, you know, on the second front, I think Mary Beth's right. Another untapped potential is the partnerships in the community and knowing what works, you know, and the fact that you really do need to engage a host of organizations in the communities to make sure that all the sort of social needs are met in order to really truly address health. And I think what we've seen with our VBID participants is that we started out small, they started out small, and kind of toeing the water with a few plans, a couple of interventions. And we have seen, you know, we can chart it, the growing interest in participating bigger with more interventions and this wonderful focus on low-income populations. And to me, that's like the perfect storm right now. And so we're just really excited to see what comes in for 2023 in terms of our applicants and VBID participants. You know, just really excited. But you know, I want to pass it to Joy because she could probably add color to everything I've kind of just referenced.
How about it, Joy? What can you add, especially on education, engagement, partnerships, Joy?
Sure. So I would say, you know, there's a myriad of places that we're engaging in and educating in, and whether it's through, like I mentioned, our Bold Goal community, which is specific communities around the country where we invest heavily either with our foundation or otherwise, and really find out the needs of our communities. And, you know, it is some of those basic things like, you know, all the basics that you need on the hierarchy of needs. It's food, it's transportation, it's it is, there are some home security issues as well, or home insecurity issues. So it's really looking at the full spectrum of needs. It's often you'll see multi-generational needs that impact, some of the living situations of our members. It's not just them, it's their spouse, it's their children, it's their children's children. So we really have a fuller picture of what's impacting these homes and these families. I would say, it's whether it's, some of our different care teams and care coordination teams that are having very rich conversations, and we're pulling that information constantly back to the office so that we can make sure we're positioning things in the right way. And, as Laurie mentioned, it really is a dipping a toe in situation where you will try or you will pilot, just in a few plans, we're going to try in a few markets this particular type of benefit to make sure we are offering what's appropriate and what's needed. Going back to air conditioners, they don't need so many in Maine, so certainly don't bring it there, but think about what's right and what's appropriate. It's the best part about VBID, honestly, is you're able to target needs that aren't normally something that's considered healthcare or was considered healthcare. And, kind of to that pilot to real and making it part of the benefit, with that lever that was flipped in 2018 that allowed for greater expansion, it also allowed us to get more creative in other areas. I'm very excited about the work we're doing around home care. This is a consistent need that often when you're able to provide certain levels of home care, one, it often gives a level of respite to those that are in the home. It allows, a greater focus in stabilizing someone and keeping them where they want to be cared for, but providing and wrapping around some of those, they're often considered, non-skilled, which I don't love the term at all, but kind of non-skilled services that are those homemaker services, or those, it's also an extra set of eyes in the home so they can report back, we're really worried about Miss Jane. It looks like she's got that leased floorboard that Mary Beth talked about, or needed a grab bar. So it's entry in, and it brings back information so we can let the member know about other services we'd be able to connect them with to stabilize them and improve their lives.
So Joy, and by the way, we're adding to our list, which is helping me a lot insofar as what's the scope of supplemental benefits. I appreciate that in the last few minutes, we've heard about, companionship to address isolation, home care, home security, you added as well. We heard earlier about home improvement. So Joy, how successful have you been in Humana in educating and getting people to actually do these things? Is there any gap between the supplemental benefits for which your population is eligible in that set and where they really are now? Is there a gap to close there? Do you need further outreach to make that happen?
So just to fully understand, so, are there more needs that our members have? Sure, absolutely. But sometimes we have to be very mindful of the population that they don't necessarily want to tap what's offered. There's, making sure that we make sure we're offering the right things to the right population, so that we're getting the best value for these supplemental dollars. So it's constantly a pullback of data and a push out of benefits, so to speak. So we're really, it's working through analytics here at the office, but then also that one-on-one personal conversations and connections that we make with referrals from other clinicians into their health records that we find out about, so that we're able to improve their lives. So is there more work to do? Always. I was going to say it wouldn't be the human condition if we weren't always striving towards improving it for others. But there's also the thinking about kind of what's next and what we can bring to our partners at CMMI and talk to them about, here's an area of need that we want to explore and go after. And I think that's also always on the list too. What's that next home care? What's that next food? What's that next, what's that next thing to offer folks that will be meaningful and transformative?
So noteworthy is your whole language about this is proactive as opposed to passive. You're not waiting for someone to raise their hand and say, hey, can you help me with my air conditioner? I need one. or my floorboards, you're somehow in various frequencies or levels, you're reaching out and probing the context or environments of your beneficiaries to see what it is they might need. Now, you don't force it on them, but you're kind of detecting where there may be needs. Am I overcharacterizing that, or is that what I heard?
It's both. You know, folks can request certain things, but I think if you take most seniors and you say to them, what does your MA plan offer? They're thinking traditional medical benefits. They may think in terms of, you know, vision or hearing or dental, but they're not always picturing the full spectrum of what's available. Sometimes when it's lowering copays on drugs, that's something that they run towards as well. But I think it's that collaboration, the conversation that allows them to find out about these other benefits, because you don't want to say my plan has free food, because it's not for everyone. It's, you know, we want to ensure it's targeted and impactful. So, you know, the retirees with a good nest egg that are MA members that don't need it, you know, you don't necessarily want to target towards them. You want to go where the greatest need and impact will be.
So the take home point again then is, and two of you have alluded to this, is that VBID provides an opportunity to target the non-traditional needs. And it's using the creativity of some of your plans out there to try to figure out what those needs might be, but also proactive approach. Again, targeted. It's not for everyone. Mary Beth,
And Cliff,
go ahead, Mary Beth. Yes.
I just imagining as you're writing this list down, if appropriate, happy to share research that BMA had commissioned with Milliman that really drills down into the picture of on the MA supplemental benefit offerings for 2022. So this is really recent, and it follows in what, you know, Joy was saying, which is you have benefits. It just may be some seniors are taking advantage of the ones that they're most in need of. So when we look at those who may have chronic care conditions, and it could be, you know, heart related or diabetes related, they're going to focus on one set of benefits. But just sort of 2 points from that research, and then I'll let you look at it and add to your list, is that almost 70% of MA plans offered the meal benefit. 50% of MA plans included the transportation benefit. And food and produce benefits were the ones that were most widely offered, meeting those certain chronic conditions. So it, you know, gives an updated set of facts to identify what the need was, again, among those with those chronic conditions.
What else did you pull from Milliman, though? I wanted to ask you that. I was saving it, but what else came out of that that was either surprising or confirming?
I think it's sort of really informative, and it's about, again, I think it was Joy speaking to this, about how, you know, the community is always wanting to look forward, but at the same time having to meet that current need, is that the number of MA plans who are offering supplemental benefits increased in 35 out of 41 benefit categories. So it just shows that increase in that diversity around what those social needs were.
Got it. Lori, back to you now. Tell us a little bit more about, if you can, maybe at a high level, where your beneficiaries are with regard to accessing supplemental benefits that are available to them. Is there a way to kind of measure that or assess a gap there, whether it's in the VBID plans or elsewhere?
Oh, that's a good question. So, I mean, I think in general, you know, better data equals better insight. So, you know, we are really, I think, at the cusp. If I think of VBID in maybe tripartite, you know, first 3 years were really about, you know, testing the waters and varying benefit packages to target, you know, a few chronic conditions in a few states. And then in 20, you know, we began allowing the targeting by chronic condition and income, and more expanded rewards and incentives program. And I think plans, the concept that Joy and I both referenced, is toe in the water and beginning that process. And so now that plans realize that there is likely a good ROI on the testing and targeting, concept, and really learning how to ferret out what beneficiaries need, and they're not all the same, and so I think from that vantage point, we're very excited to to drill down with our plans and collect more data around what's happening, and really focus on the utilization, the uptake, tearing apart, who's using the benefits, and the outcomes of that based on subpopulations, and either by color, by ethnicity, by age, are there different cut points? And I think we're definitely really interested in that. I think also understanding the communities, by region, and understanding different sort of cuts that might shed light on what's the biggest bang for the buck for the Medicare program, and where we put our dollars, and where and where plans do. I think ultimately we want to make sure we're also bringing in the quotient of the high value providers, and kind of early data in year one evaluation report indicated that that there was an increased use of high value providers in the areas of like primary and specialty care, and so we want to build on that success and encourage that, and we put out a more defined, refined definition of high value provider to, include those that are treating those in underserved populations and essential community providers. So I think that's, definitely an important piece. And then I think the other piece I would talk about is the health equity incubation program that we initiated at the end of last year, and that's really just to help all plans, not only our VBID participants, but those thinking about coming in or that would never come in, but aren't necessarily able to do all the homework and research on their own. But when they're talking to their actuaries and thinking about ROI, are there ways to figure out what are meaningful drivers of healthcare in terms of social determinants of health? And we've talked about, some of them a little bit, food and food insecurity, a huge, issue for our country, and, Medicare population, and, certainly transportation, housing, all those pieces. And so we look forward to kind of refining the VBID test overall, and making sure that, we're testing in these important areas, and that we have a sort of significant set of interventions in these promising areas of focus that we can, learn a lot by the end of the test.
Well, if one were to synthesize what you said across three experts here, is it fair to say then that, I'm trying to get my vocabulary right here, VBID offers a practical laboratory to test, target, and refine and spread supplemental benefits? Does that sound about like a decent capture? Practical, it's a laboratory, you're testing it, you're targeting it, you're refining it, and ultimately spreading an evolving set of supplemental benefits. So that's kind of what we're hearing now. And so with that, I want to ask a closing question, 30 seconds apiece. And that is, so what's next? Supplemental benefits. Let's go Mary Beth, Joy, and Lori. Just 30 seconds each, like what's over your horizon? What's the next great swell thing you want to do in supplemental benefits? What do you think, Mary Beth?
I think we need to, recognize the value of supplemental benefits, and that if you have 99% of plans offering it, and you're seeing in some of the data that I gave you, the uptake that seniors are doing in accessing, transportation and nutrition, and that it's ultimately bringing them cost savings, then it's an area that we need to obviously continue to learn more about on utilization and health outcomes, but continue to invest and see the value of it. and be creative in really paying attention to the non-health needs that have to be addressed by seniors.
Yep. So recognizing value, top of the list. Thank you. Joy, what do you have? What are you looking for next?
To continue to meet our members where they are and to provide them with a more seamless experience across all forms of healthcare.
You've made a very powerful point, meeting members where they are, and then the seamless aspect as well, kind of stitching it together. Very important. Thank you. Lori, what are you looking at next?
You know, I think the health equity incubation program is a biggie, because I think it really is going to bring together all the sort of past operational sort of lessons and initial lessons from VBID and allow plans to kind of hit the ground running that are either here now with us or want to come in and, you know, test in the underserved populations, because they have the ability to do it. So, you know, and a focus on the data and insights we can glean, huge. And, you know, excited to be working with Joy and Mary Beth across the spectrum as we continue the journey.
They're all great partners. And actually, if you could pull together a seamless set of health benefits, supplemental benefits that meet your beneficiaries where they are, you will make a great bit of progress in health equity. And that's the thing. You want to close that gap. The way the three of you have described these supplemental health benefits, whether it's food, nutrition, climate, including air conditioning, transportation, home improvement, home care, home companionship, home security, and more and more and more, that's the way to do it. So Joy Cameron, Lori McWright, Mary Beth Donahue, thank you for educating all of us on what these are, how they work, how to expand them, and how they all feed into closing disparities and achieving greater health equity. Thank you all very, very much. Great session. Wonderful. Okay.
Thank you. Our pleasure. Take care.
Thank you, Cliff. Thanks for the opportunity.
You got it. We'll do it again. We're going to take a 15-minute break now till the top of the hour. When we reconvene at 2 o'clock Eastern, we're going to look at progress in measuring and reducing low-value care. And then our final session following that is going to be the problem and the big problem of underinsurance and potential solutions for that. See you at the top of the hour, everybody. Okay, we're going to reconvene. Do I see Rita there? And Nancy? And Erica? I'm seeing folks, but not hearing them.
Okay, I found the microphone to unmute.
Okay, good. And you can hear me, Rita?
I hear you fine. I'm going to put my wireless in and see if that sounds any better to you. I can do either.
You sound okay now. It's not bad. Yeah.
And so can you hear me, Cliff?
Yes, we can, Nancy and Erica. And Nancy both?
Okay.
Yes.
And you hear me?
Okay. I couldn't hear Nancy. Did you try again, Nancy?
Hey, Erica, I don't think I've seen you since our conference
Muted
at
by
Yale.
the organizer, but now here I am. I don't have to do sign language, which I'm not very good at.
Well, welcome back,
Rita,
everyone.
you too.
This is our third session in our Enhancing Health Equity VBID Summit of 2022. And this addresses progress in measuring and reducing low-value care. And some of the issues that we're going to talk about are just kind of how you get involved in doing this, multiple stakeholder engagement, measurement, and evidence, and maybe even advances in the field along the way and a few more bits as well. I'd like to ask each of our panelists to introduce themselves, starting with Rita, and just kind of basically name, affiliation, and Rita, how it is you find yourself on a session with this title. Rita?
Sure. Well, I'll take a few minutes to go back to my origins back in Brooklyn, New York, where I grew up. And as my daughters like to remind me, way before it was hip. And really the part Brooklyn I grew up in is still not hip, but I will say that a few years before me, Ruth Bader Ginsburg graduated from the same high school I went to, and actually our current, well, Chuck Schumer as well. But I mentioned that more, actually neither of my parents graduated from high school. My father got a GED after he was in the Army. But we grew up in pretty modest circumstances, and it was drilled into me not to waste things. I think my parents were very, the original reuser and recycler, which obviously we do now for environmental reasons, but it really was a lot financial. And so I have a very strong ethic not to waste. And I think I was very lucky to go to Cornell on a full scholarship, and then to University of Pennsylvania Medical School, where I had the good fortune to work with John Eisenberg, who probably some of you know, but at that time he was the chief of general internal medicine, and I wanted to be a general internist. And he was doing a project on understanding why house staff ordered daily inpatient laboratories like electrolytes and things on our hospital inpatients every morning. And so, which was just part of the routine labs, which had never occurred to me to question that, but he would send them notes and say, what did you learn from this chemistry panel, and how did it help in the care of your patients, and did it lead to any changes in management? And sending these notes had really no impact on the test ordering behavior of the house staff, but it had a huge impact on me as a second-year medical student, because it made me start to realize that things I took for granted that were done every day in the hospital didn't always have an evidence base, and perhaps weren't always going to improve patient care. And it really changed my whole sort of orientation to what I planned to do. And then I decided at that time that I was going to do sort of work on our big picture healthcare system and understanding the evidence base behind what we do and why we spend so much money on healthcare in the US, way more than the second highest spender by far. And yet our health outcomes are not nearly as good as countries that spend a lot less. So I ended up taking, I got a fellowship from the University of Pennsylvania, the Toron Fellowship, and studied at the London School of Economics for a year in between my third and fourth year of medical school, and to study health policy, and also got to see the National Health Service, a capitated system that spends a lot less than we do, and it has guaranteed access. Every person in Great Britain has medical coverage, which we can't say in this country, even though we spend a lot more on medical care. So it really sort of launched me on this idea of looking at the underpinnings of what we do. And frankly, I'm a cardiologist at UCSF. I should have said that. I'm also editor of JAM Internal Medicine. But I went into cardiology not just because it's fascinating clinically and a great field and lots of things we can do for patients, but also because I think a lot of what we waste money on is technology, and cardiology is a very high-tech specialty. So it's been very helpful to me to understand sort of better cardiology and devices, and a lot of my work now is on the evidence behind medical devices and low-value care. And I have been very fortunate to have a grant from the Arnold Ventures Foundation on reducing low-value care, because once you identify it, you really want to then actually work to change the system and try to improve things.
Well, that qualifies
That's how I got into it.
That qualifies you for this panel, certainly. Thank you, Rita. Over to Nancy. Nancy, describe who you are in the Washington Health Alliance and how it is your job suits or meets the needs of this panel. What's the match?
Thanks, Cliff, and pleasure to be with everyone. So I'm Nancy Gento. I'm the Executive Director of the Washington Health Alliance, and I lead a very small, not-for-profit, $3 million organization with a very big and vision. We represent 185 member organizations across the state of Washington, including all of the stakeholders, purchasers, meaning employers and union trust, health plan leaders and providers across the state. And our work is really threefold. First of all, we publicly report on performance measures that's driven by a very robust voluntary all-payer claims database that we run. We also do a tremendous amount of work around convening and bringing folks together around difficult and challenging issues. We're a trusted, unbiased convener, and we work really hard to drive change. We believe data in and of itself is not enough, that you have to really have trusted relationships that help you drive change. So that's my organization in a nutshell.
Thanks very much, Nancy. And I had forgotten about your all-payer claims database, one of the leaders. Thank you. Erica, over to you and your role with Arnold.
Sure, great. Thank you, Cliff, and thank you so much for having me today. I'm really delighted to be here. So my name is Erica Sacker. I'm a vice president on the healthcare team at Arnold Ventures. For those of you that aren't familiar with Arnold Ventures, we're a philanthropy. We're focused on developing evidence-based solutions to pressing domestic policy problems, and that includes in the healthcare space. And so on the team here, I lead our work on provider payment reform and on Medicare sustainability, as well as work to improve the affordability in the commercial insurance market. Kind of how we got into this space, we really approach our work through a lens of cost containment and trying to improve affordability in the system. There's like a variety of reasons we're interested in that, some of which Rita alluded to. We pay a lot more than other countries for care, not getting better quality as a result of spending more. We don't have a very high value system. And so for us, when we kind of step back and look at the different cost drivers, I think the issue of low value care and of overuse in certain areas comes up as a really important driver to focus on working on. Just as some examples, if you look at the Medicare program and projected spending over the next decade, a lot of that is really driven by increases in volume and intensity of services. And I think that the technologies that are coming online, something that Rita mentioned as well, kind of how technologies drive some of this. With some of the new technologies, I think a good example is telehealth. This is a problem that could be getting worse, particularly if we continue under the fee-for-service system that we have. And so we're doing a variety of work to try to get at some of the barriers of reducing low-value care and help supporting that through both evidence generation, policy development, and then also a lot of technical assistance and implementation work as well. So just to echo something that Nancy said, we firmly believe in the evidence and in the research, but we don't think that that's sufficient. And so we have a very strong emphasis on driving policy change and driving changes in practice so that we can actually take that evidence and kind of act on it and do something to reduce low value care. So hopefully that gives you a better sense of how we're approaching the issue.
It does, and we're going to kind of go a little bit further in depth on that in a few minutes. And as a matter of fact, maybe even starting with Nancy here, I want to ask each of you, let's go Nancy, Erica, Rita. Tell us at a high level about an example or two in which you are engaged that really is about measuring and or reducing low value care. Nancy, what's a really good example, contemporary example of what the Alliance is doing now programmatically to achieve that? High level, nutshell description.
So like Rita, we enjoy wonderful support from Arnold Ventures, Erica and her team. We, in phase 1, launched an initiative to try to align around value. And in that work, we brought together purchasers representing about 550,000 lives in the state of Washington and looked at both high and low value care and asked, what do we work on together here? What do we have a common goal? And that group selected low back pain. And currently we are working again with support from Arnold, wonderful thought partners and supporters in this work, on a low back pain implementation collaborative where our aim is to improve the care for low back pain of all patients in the state of Washington. We have 29 organizations representing all the stakeholders who've been engaged in this work with us since the launch on February 3rd. We have extraordinarily active involvement, lots of enthusiasm. We're at the point in that project right now where we're identifying the levers to drive change by stakeholder group and the measures that will help us afford that change in the Washington market.
Nancy, is there anything particularly innovative about that or anything you learned about bringing on your 29 organizations into this collaborative? What sort of revealed itself to you and or what was particularly innovative about this venture?
Yeah. Well, I think Cliff, that it's data driven for starters. You know, it started with data, and we pride ourselves in the trusted data that we produce. It started there, but really it's about engaging folks in the conversation. It's very powerful when you have a room full of health plan leaders and purchasing leaders and providers. You know, we have around this table specialists in the state of Washington from many different systems who know the direct care of back pain patients and know the challenges to it. And when you have them talking to one another candidly about what's not working in the system, there's some magic that we hope occurs. Okay. And I'm not saying that that's particularly unique or profound, but you have to set the table well, and you have to invite the conversation, and you have to disallow entrenchment into individual silos. You have to pull that out so people are talking to one another.
Aha. Actually, before we go to Erica, because she may talk about several different ones, I want to go to Rita. Rita, can you give us an example or two of sort of a programmatic intervention, whether it's funded by Arnold or anyone else, what you're doing as far as measuring and or reducing low value care? And is there anything particularly innovative about it and or anything revealing about the experience thus far?
Sure. So actually it is the work we're doing funded by Arnold that I think is innovative in, you know, sharing a lot of the features. I think that what Nancy has described, you know, we work with stakeholders. So we've partnered with some state Medicaid groups, in particular the managed care organization, because I think, as Erica mentioned, sort of the structure of healthcare delivery in this country, and particularly the fee-for-service structure, really sort of incentivizes low value care, unfortunately, which gets reimbursed at the same rate as high value care. So we've partnered with some Medicaid managed care programs, and we work with them to identify, you know, because there's a long list of low value procedures, which ones are most relevant to their policies, their stakeholders, and their patients. You know, what are the number of patients affected? What are the harms that come from this low value care? Because if there's not really any benefit, then you're only left with harms. And then what I think, to me, that's exciting and innovative is that we can then work on implementation. So then on developing policies that decrease incentives for low value care. And then we're going to measure, you know, have these policies been effective? did we reduce low value care? And then the overall goal then, of course, is to have the funds to reallocate to high value care, because we know that while some people are getting too much care, other people are not getting enough care. And so we're really excited and think it's innovative, and hope that we're able to sort of launch this and then partner with many insurers and payers.
Can you say a little bit more, Rita, about how the various stakeholders are involved in this? Who needs to be part of this, the arrangement here, and what is each of them briefly seeking?
Was that question for me, Cliff?
Yes,
I'm sorry.
for Rita. Yes, Rita.
So you're asking who are the stakeholders?
Yes, who's participating and what's in it for each of them?
Okay, so mainly the Medicaid, the MCO medical directors. Well, first of all, I have a team at UCSF, so we're all physicians in some way that are, anxious to improve the healthcare system and to identify low value care. So we do a lot of the evidence reviews and look at the data. And then we partner with Medicaid medical directors who are interested. They have a fixed budget and they need to provide, the best care they can within that budget to their population. And so those are our stakeholders. And then we just, of course, try to get input, from other cardiologist practitioners in the state that are going to be affected and by these policies. So if it's, say, an ENT policy, we have one on sinuplasty. We talk to those practitioners in the state to make sure that they're on board with the program.
Got it. Good. Thanks, Rita. So Erica, you've been invoked a couple times already from the kinds of things you've been funding. So give us an idea, Erica, about sort of the shape and depth of your program in this particular area, i.e. measuring and reducing low value care. What is it? Is it bigger than a bread box, and what does it look like?
Yeah, I can mention a couple things, and I'll focus on some things that maybe Nancy and Rita haven't highlighted to kind of feature a couple of other efforts. So one thing that's really top of our list right now is working on reforms to the financial incentives that are facing providers. We think it is essential to make progress on this issue, to move away from the fee-for-service system and to move to alternative payment models. And so we're doing a lot of work to support the adoption, kind of broader adoption of accountable care organizations and other population-based payment models in particular. Really think that the evidence points to those as models that are most likely to be effective at reducing costs, but also keeping quality the same or even improving it in some cases. And there are some evidence as well that ACOs have modest reductions in low value care. And I think as ACOs kind of get more experience with that and maybe move down to like number 3 and 5 on their priority list and not number 1, we might see more happening there. So we're doing a lot of work on that right now. And I would say some of that is research work, but a lot of it is also policy development and kind of more practical technical assistance and implementation support, both for ACOs, but also for federal agencies like CMS and CMMI too. And I think there's a real opportunity there given the kind of ambitious goals that have been laid out by the administration around trying to get the vast majority of beneficiaries into accountable care relationships by 2030. And I think like part of how I think about that in relation to the low value care issue, I mean, we have done some work that goes more kind of service by service and tries to reduce low value care on particular measures. And I think that work is valuable and there is a place for it. But I think we have also seen that so much of low value care is really situational, and there's an incredible amount of clinical nuance here. And so I think the promise of the accountable care organizations is that you can really get like the high level kind of overarching incentives right, and make sure that you're not asking providers to work against their financial interest, which I just don't think is a realistic thing to do. So that's kind of one bucket of things. And then I would say one other thing which has come up a little bit, but just maybe to say a bit more about it, we're also doing some work around trying to improve the identification and measurement of low value care. And so some of this is related to state measurement efforts, like some of the work that Nancy and the Washington Health Alliance have done. But we're also interested in working with some people that are developing kind of more more specific measures of low value care that look at low value care for certain specialties and really can get at like the health system level measure of low value care. I think that's really important because we've made a lot of progress with things like the Milliman waste calculator, but a lot of the other measures of low value care have really looked at geographic or regional variation in this, and they're not really like actionable measures that you could incorporate into performance systems or into payment that tie to a specific provider system. And they're not really specific enough for an employer that is designing their network, for example, to select the high value providers, or for an ACO to think about referrals to high value specialists. And so we're doing some work with researchers as well to kind of help expand the ability to have those sorts of measures.
I want to come back. I'm going to ask all three of you a little bit about measurement and evidence, but each of you in a certain way has made direct or indirect implication or effect that reducing low value care creates some headroom for supporting high value care. Now, we'd all like for this to happen. Do we know so far that it is happening? And I'm asking because each of you is involved in multiple organizations, multiple stakeholders, and each of you has multiple stakeholders in a given program, some of whom might benefit if they could save some bucks here to spend some money on high value. Is that panning out, Nancy? Start with you. Is it panning out that way?
Well, I think in the state of Washington, Cliff, we have anecdotal evidence, but probably not hard, solid evidence. You know, I would say that when we work with purchasers, they're very hungry to learn about the evidence base. They want to do the right thing. They're interested in how to incorporate it into benefit design and how to incent it. And I think that they're, you know, everyone is driven by a cost motive. That's fundamentally important given how unaffordable healthcare is in our country. But, you know, employers are also very concerned that they have a well workforce and that people are productive and, you know, are able to be at work and fully executing against assignments. So I think the motives are on both sides of the equation. And you know, we've certainly seen evidence of employers, you know, looking at screening information and wasteful care and making modifications to health and benefit designs and wellness programs. And we see payers, you know, taking action in that regard. And I think providers, you know, I've worked with physicians all my life. I'm a former hospital administrator. You know, doctors are trained and dedicated toward a patient's health. And yep. You know, the incentives, I agree completely with Erica, the incentives have to be better aligned for them to do the right thing.
Right. Well, so Rita, you expressed earlier your frugality. And so do you see that this can actually come to pass? We can save money here by avoiding low value care and resupplying it to high value services. Is there a mechanism in place to do this in the environment to which you referred earlier?
Well, that's a great question. I mean, I think low value care has a lot of ramifications besides cost. So I think I just want to underline, you know, to me, the primary advantage is that you're avoiding care that isn't going to help someone and then can only harm them. Because a lot of people, you know, even if the care was free, you don't want to get care that isn't likely to help you because you're always at risk for the harms. And I'm sure we've all, and I've certainly seen a lot of terrible, tragic cases of people who had care they would have been better off without. But then there are the financial costs, and it is unfortunate, as Erica said, that in a fee-for-service system, there are unfortunately not really a lot of incentives, certainly for providers and not much for patients either, to avoid low-value care. And so I don't know that all, and that's why moving, as you said, to policy design like ACO, and that's why, you know, we've started with managed care systems because you're much more likely on a fixed budget to be looking at how you spend your care and then to reallocate from low value to high value than you are in a system like Medicare fee-for-service, most of our private systems where there's just more money thrown in. I mean, that's how, when I was studying social health policy at London School of Economics in the early 80s, let's say, we were at 9% of GDP on healthcare in the US, and everyone said it's going to be a watershed moment when we get into double digits, and then people will really buckle down and stop wasting so much money on high-tech things that haven't been shown to work. Well, as you know, we're like now approaching 20% of our GDP. So I don't think necessarily you can say that reducing low-value care is going to reallocate to high-value care. It's just more care.
Right, and it depends on the system, as you
one
just said.
person wasted
Right.
care is another person's profit. I'm sorry to say.
I won't fight you on that. Let's put it that way. Erica, from a programmatic standpoint at Arnold, are you able to see how funds that are saved by not pursuing low-value care find their way into high-value care?
Yeah, so I don't know that we have seen that directly, like to Nancy's point about, like, I don't think we've seen that clearly in the data so far, but I think in some ways, like, that is the promise of ACOs. One thing that we have seen is that the physician-led ACOs have been more successful than hospital-based ACOs. And some of that is that the financial incentives are more aligned and that you're creating a situation where you're reducing some of the spending that is wasteful, that's often happening in hospital-based settings, or that's happening with kind of high-margin specialists, and you're allowing like a primary care doctor or a different physician to kind of benefit from that and receive some shared savings from that. And so that, I think, gives them an incentive because they're not reducing their own revenue, but also it does reallocate some resources to other providers that might be providing very high value services. The other thing I would add is that a lot of the measures, when we look at quality measures that are being used in the ACO program, but also in Medicare Advantage and other places, a lot of those measures really focus on places where we think there is underuse and are creating incentives to provide necessary screenings or to provide vaccinations where they should be and things like that. I think we don't see as much on the flip side where there aren't really measures of places where there's overuse in those performance systems. And so I think, you know, we haven't seen a lot of this play out very directly, but I think there's reason to think that some of these different reforms do help shift resources around the system. And I think there's ways we can think about doing that more directly, for example, in the way that we're thinking about risk adjustment, the way that we're thinking about setting the benchmarks for ACOs and things like that.
It does sound like the ACOs are a good venue. Go ahead, Nancy.
May I just add one more? So as I'm listening to Rita and Erica, one more thought comes to mind. So we have a particularly progressive employer in the Seattle market, aggressive in a very positive way, works with a large number of labor unions. And many years ago, they went to a compensation structure whereby savings, a portion of savings from benefits, you know, got incorporated into a total compensation structure. So brought their employee base right into a conversation about what's high value and low value care, and really have made tremendous traction over the years. They're probably one of the best examples I know of in the state of Washington where that's happening.
So the secret was there what? The secret there was what?
I think the secret there was to figure out how to align the incentives between employer and employee, you know, and get figured out the way to communicate, and again, set the table in a way that it's a constructive, you know, conversation that yields results, positive results for both.
Got it. Good. I'm taking a good guess at what that industry was, what the big employer was out there.
No, you may not. You may not guess this one.
Oh, okay. Well, you can share it.
It's actually a municipal organization.
Oh, I was thinking of someone else.
I know you probably were.
Maybe with wings or something like that.
We're
yes.
also wonderful and innovative and terrific and all that.
Okay, that's what I thought you'd talk about. So, Erica, just back to you for a minute here, and then I want to hear from Rita and Nancy. We want to hear from Rita and Nancy as well on this. Back on measurement and evidence, you talked about using the Milliman calculator. You also talked about actionable evidence and so forth. Could you elaborate a little bit more on what are the main sources of data, which isn't the same as evidence, of course, related to assessing low value care? Where are you kind of diving into data? Who synthesizes it? How does it apply to low value care? Measurement and evidence.
Sure, I can start on that. So I think like ideally we would have more of the measurement be things that can be specified using the claims data. Administrative claims are like the most widely available. It is easier for people to kind of use that to identify and to make payment changes and things along those lines based on low value care measures. I think the challenge is, as I said, that a lot of low value care is really situational. And then when you get down to like, is this care low value care for this specific patient in this instance, often you need additional clinical information to be able to decide that. But I think that we have made progress through choosing wisely and building off that, and then resulting in the waste calculator and being able to quantify some low value care, which I think has been very helpful for being able to quantify the size of the problem, show how frequently it occurs, and also to help target the intervention effort. Some of the interventions to reduce low value care, it's a lot of work and it's a lot of change for the system in terms of changing clinical workflows and things along those lines, and being able to really pinpoint where we think are some of the most promising opportunities to reduce low value care, both from a harms perspective, but also from a cost savings perspective, I think is really useful. In terms of kind of newer measurement strategies, as I was saying, we are working with some researchers to develop more kind of system level specific and specialty measures, which I think can help to capture more kind of high dollar areas of low value care. One often critique that we've heard about things that are captured in the waste calculator, I think if you look at the downstream savings and what happens with the care cascade, so you get an initial test, it might not be that expensive, but then what is all the care that happens after that that shouldn't have happened? Those numbers start to look pretty large, but often the initial test is not necessarily that costly. And so it is hard sometimes to make people see like the value in making all these changes to go after something of that cost. And so I think focusing on some of the high cost specialty areas can also provide more of a motivation to actually enact reforms that start to get at that. One specific example would be like orthopedics and thinking about like spinal fusion versus physical therapy. So that hopefully gives you an example.
Well, I also like the point you made insofar as needing to look downstream for the costs that are generated in sort of a domino effect or cascading effect. It might be an inexpensive initial test, but that kind of snowballs into something else. I think Rita made a similar point there. But so we need administrative claims. Sometimes you can spice it up with clinical information. And those are like two of the main sources of data to try to make this happen. Not the only ones, but two of the main sources, correct?
Yeah, I think that's right. I mean, I think it is also really important in creating these measures to look at what the clinical evidence says and clinical guidelines and things like that. But yeah, I think you summed it up.
Okay,
Yeah,
good. Well,
I would just
go ahead,
add,
Nancy.
you know, that the more and more, I think all of our organizations are talking about diversity, equity, inclusion, and adding that lens to the work that we do is really important at the Alliance. We're using work from the University of Wisconsin called their Area Deprivation Index. ADI is what we reference it as. And in this last round of submissions from our 35 data submitters, they're helping us with deciles that match that. And we hope to overlay that social determinant of health lens over the work that we do, including the quality and total cost of care work that we do. I think that's important insight because I think if you look at a measure, you know, you may be topping out in the state, like doing super well on a particular measure, but if you isolate that by zip code or some other way to get at potential deprivation, you might learn an extraordinary amount.
Is the ADI is the one that has like, what, 15 or 20 variables in it?
Yes, it's a very robust tool, Cliff.
Right.
Yeah, very
and
robust.
It gets down to census blocks, I think. It's even smaller than zip codes, right? Yes. Okay, very helpful tool. So Rita, you're an evidence person, and I know you're a guidelines person. So when you think about measurement and evidence in the space of low value care, upon what sources are you drawing?
So just to reiterate what Nancy and Erica have already said. I mean, certainly claims data is what, the most widely available and is useful for some measures, but, more for things like if, for example, the U.S. Preventive Services Task Force generally recommends we stop or have a very individual approach to cancer screenings after age 75. So it's easy to pick age out of a administrative claims database. As Erica said, for the situational ones where it depends a lot more on symptoms, or are you already on medical therapy? Have you failed? Things like that. A lot harder to get that from the medical record. And that's where we sort of look to other policies and changing the whole structure of the system. I mean, honestly, I think there are a lot of advantages to a capitated system, because then you're giving the providers the pot of money and saying, you make the decisions on how to best take care of your patients with this pot of money, because it's so hard to go micromanage. I think registries are another source, but I think that we have very few registries, particularly that are publicly available. We have some that are proprietary, and those are very difficult to work with and get access to, unfortunately. In other countries, for example, we've learned about metal on metal hip, because Britain and other countries had much better data registries than we did, and found out, they were about high revision rates and things like that. Mm-hmm. So I think currently, we use claims data because that's what's available, but we could have much better systems. And I think realigning incentives, like in a capitated system, is a really better approach. And I do want to just emphasize the point Erica made about downstream testing, because people, the problem with a claim, just looking at claims, is that you're not going to pick up, that back surgery that went bad and then, led to repeat surgeries, a lot of pain and suffering, loss of employment. I mean, there are so many downstream effects. In cardiology, I see it, people think, oh, now everyone likes to get a cardiac CT just to assure themselves their coronaries are, well, you don't know what you're going to see. It's not going to help you at all. But yet it can lead to a lot more testing. You might, see some lung nodule you didn't need to know about, but once you saw it, it's not going away. It's like you've let the genie out of the bottle. And there are a lot of costs to those care, both financial and also psychological. You've taken someone who thought they were healthy, and now they're worried about something they didn't even know they had, and they would have never known they had, and frankly, they would have been better off not knowing.
So Rita, then let me ask, so toward reducing low value care, we've heard about claims, a little bit about other clinical information. You mentioned registries. What data or tools or analytical tools, what data or analytical tools would you like to see drawn upon or implemented that would actually get us closer to zeroing in on low value care, either identifying low value care or using data to feedback to reduce it itself? What are those pieces?
Well, I think really better data systems. So, systems where we're actually tracking what happens to our patients, kind of like, I think the Scandinavians tend to do that very well. So they can, look at how do people do. We have very short-term windows on how people are doing in our system. And then if even with claims data, if they change insurers, as people often do after a few years, then we don't have that long-term data. It was 10 or 12 years ago, we were supposed to get unique device identifiers for devices. We can't even track devices in our medical records now. For a country as supremely advanced as the US, we have very poor tracking and very poor patient registries.
True enough. And I know you've got experience, I've got a little too, with regard to Medicare and coverage with evidence development and trying to draw on registries from time to time, more or less successful over time, including cardiology, by the way. Nancy, just want to get your thoughts on that as well, insofar as better, more data sources and analytical tools to pursue low value care and actually do something about it.
I agree with what Rita said, a link to outcomes. And I would just say, so in the Alliance database, we can track longitudinally. And, it's really important stuff, because you need to know what happened to that patient over time, and you need to know when that patient changed providers and changed health plans, that you've got the same person, de-identified naturally, but that's how we look at data. But I agree with Rita on the outcomes front, really important to link that. And, you know, from an employer standpoint, it's, did they get back to work or not? Were they productive and able to get back to work as quickly as possible? That's their outcome measure.
So Nancy, tell us a little bit more from this Alliance's standpoint. What else could the Alliance, do you have sort of a wish list for data or analytical tools that would help you pursue this more directly? I mean, you have practical experience in doing this, pulling together partnerships. What data do you have? You've got the all-payer claims database, but what else do you need?
I mean, I think there are organizations that are beginning to experiment with how to link EHR outcome data to claims, and I think that's a really important topic. You know, it is a monumental task to do, and to do it well. And I think, honestly, Cliff, I've said this, you know, a couple times here, sometimes the technology end is the easy end. It's the, am I going to trust you? Am I going to trust you with this level of information that you're going to keep it secure and treat it, you know, with the respect and protection and security that it deserves? So oftentimes it's not the technical challenge. It's, do you have trust of the players so that you can bring it all together to drive the change?
Yeah, you've kind of delivered that with quite a bit of power. I was not thinking going into this that the kind of partnership trust thing was going to be such a big deal, but I guess it must be. Is that because your all-payer claims database has been a success and it kind of relies on mutual trust in the state of Washington?
I think so, Cliff. And I mean, I'm really proud to share that yesterday the Alliance Board of Directors approved release of a total cost of care look at the medical group level in a pretty detailed look at how medical groups and clinics across the state are spending on care. And I would just quickly add, you know, we have a pretty robust committee structure that helps drive this work. I give a lot of credit to medical leaders in the state who have the courage to stand up and be counted and help drive this work and say, okay, release it. And a board, multi-stakeholder board that says, let's go, you know.
So
really
it can happen.
Yeah.
All right. All right. Well, a closing question for each of you to answer in 30 seconds or so, maybe a minute if you sound real good, great idea. And that is, all of you from your respective perspectives have expressed what you've done to reduce low value care, maybe what you'd like to do, whether within your own purview or a broader national purview. Where do you see the highest potential yield for minimizing low value care? If you could kind of pull a lever, push a button, make one thing happen, where's that greatest opportunity to make a big, measurable, or as Eric would say, an actionable difference in low value care? In the feasible set, by the way. So just within 30 seconds or so, let's go Rita, Eric, and Nancy on this. Rita, what's the biggest potential yield here to knock down low value care? What is it?
Well, I think it would be getting away from fee-for-service medicine towards sort of value-based care. And I think that is feasible. I mean, it is what a previous HHS secretary, had set as a goal under the Obama administration, I think. And I do think it's feasible. I have a lot of my colleagues say we should get rid of fee-for-service medicine. I mean, it just does not reward the right behavior. And I'll just add, I also think we need to sort of change culture, because now we've got a culture towards more is better. And so that means medical education and all kinds of things have to change too. And I think they would with a change in delivery system alignment.
So set fee for service aside permanently. So yours is a system-wide change that also demands a cultural change, or would rely in part on a cultural change.
Right. We would move. I mean, people could still purchase whatever care they wanted, but I think our primary means of, ensuring would be through a system that doesn't emphasize volume, but emphasizes high value care.
Got it. Good. Thank you. Erica, 30 seconds. What's the big yield there? And then Nancy, same.
Sure. So I agree with Rita. I mean, I think it's really moving away from fee for service and moving to more of these total cost of care models where providers are accountable for total cost of care and for the quality outcomes for their patients. I think that is kind of the most meaningful thing we can do. Like Rita, I think that's feasible. We've made a lot of progress over the past decade in particular, and I think know a lot more now about what works and what doesn't, and how to make the existing models stronger to strengthen the incentives to participate, strengthen the incentives to reduce unnecessary utilization. And I think to some extent, it really is a question of will and needing to move more aggressively in that direction. There is a lot of inertia in the provider space, and I think there are providers that really see value-based care as kind of the future and are more like the first adopters of that. But to move some of the more reluctant parts of the system towards these models, like we do really need to send a clear signal that this is the direction we're going. We need to move more aggressively towards alternative payment models. And we also can't forget about the need to make changes in fee-for-service. Fee-for-service is still a pretty comfortable place for most providers to stay. A lot of providers are making a lot of money there, often off of low-value services. And so thinking about ways we can make that a less attractive place to be and the alternative payment model is a more attractive place to be, I think is a really important next step.
So maybe not eliminate fee-for-service, but squeeze it down, at the same time expand APMs, alternative payment models, provide the incentives, and get the will. Final 30 seconds, Nancy. What's your big yield here?
I think Rita and Erica are just spot on. I'd be 3 for 3 here, and I would just add drive change through a collaborative multi-stakeholder effort where folks are talking to one another.
And yours has been a great model for that. Thank you, Nancy. Well, if you wanted to figure out how to make progress in measuring and reducing low-value care, you could go to 3 people who are actually doing it. And great thanks to Rita Redberg, Nancy Junto, and Erica Sacher. You are indeed leaders, and we will continue to follow, and maybe someday maybe surpass you. We'll see, but you're setting the best possible examples. Thank you all very much. Much appreciated.
Thank you.
Thank you.
Great job. Thank you. All righty. Okay, we're going to move to session 4 now and talk about a difficult problem that's getting more difficult lately. We're going to move now to the problem of underinsurance and potential solutions. And good gosh, we could use some solutions here. We're joined by Sarah Collins, Katie Spangler, and Amy Niles. And as before, I want to ask each of them to introduce themselves by saying kind of who they are, what their organization is, and how what they do, how what you do, flows into the issue of the problem of underinsurance. So let's start with Sarah Collins. Sarah?
Hi, I thank you, Cliff. And I just want to also thank Mark and the VBID Center for this symposium. And really, there are years-long effort on making healthcare more affordable for working families. I am Vice President for Healthcare Coverage and Access at Commonwealth Fund. My colleague, Dr. Lori Zeffrin, was on earlier, so she gave, I think, a good overview of what the Commonwealth Fund does. I direct our research agenda on coverage and access and also lead our research initiative on tracking health system performance. We have been tracking the issue of underinsurance since about 2003 when we introduced a measure on our biennial health insurance survey. And we also do a lot of analyses of employer plans using federal data, and I'll talk about those later.
Great, thanks very much, Sarah. Over to Katie.
Great. Good afternoon, Cliff. So it's such a pleasure to be with everyone today. So I am Katie Spangler with Spangler Strategies, and I am also a co-director of the Smarter Healthcare Coalition, which is a group of very diverse stakeholders ranging from Families USA to the US Chamber of Commerce to AHIP to pharma, and lots of folks in between. And we are very focused on increasing adoption of value-based insurance design and value-based payment reform. I'm delighted to say, Cliff, that I think we have an initiative on almost every topic that we've heard from folks today. So we're doing a lot to bring more VBID into Medicare Advantage, working to address social determinants of health through the benefit design, working to decrease low value care, and then also excitingly what I'm going to talk about today is expanding pre-deductible coverage of high value care.
Yes, and we do want to get to that, and you're the person from whom we can get the most on it. Thanks, Katie Spangler. Over to Amy Niles.
Hi, Cliff, and I want to thank you and Mark and Susan for inviting me and the PAN Foundation to be on this panel. It's really a privilege to be here with Sarah and Katie. I'm Amy Niles. I'm Executive Vice President with the Patient Access Network Foundation. Most people know our foundation as the PAN Foundation. We are a charitable foundation that since 2004 has helped more than 1 million people, all of whom are underinsured and most of whom are Medicare beneficiaries. We've helped them access the prescription medications that they need for their treatment by providing grants to cover their out-of-pocket costs. And as everyone here knows, these out-of-pocket costs can be extremely high. And for individuals living on modest low incomes, being able to afford these medications is extraordinarily challenging. So we are honored to be able to provide this assistance. We know that 1 million people is a lot of people, but there are a lot more people who need help. We do this, we provide the support through about 70 different financial assistance programs that we operate today, covering a range of cancers, chronic conditions, and rare diseases. We'll get into the tremendous challenges that the underinsured face, but in addition to the financial assistance, we are increasingly concerned, and there's been so much conversation in this summit to date, which I've been really happy to see, about social determinants of health and the impact that that can have on people's ability to access the care that they need. On top of that, we know that the underinsured, we have a very complex health ecosystem, and it's really hard to navigate. So we, along with others, hope to play an increasing role in helping in people who are underinsured understand what they need and where to go. At the end of the day, we believe everyone should have access to affordable care. So we all have a lot of work to do.
We sure do, Amy, and you are doing some of that, I know, with PAN, and we're going to come back to you a little bit later in Part D, so I know you'll be teed up for that. I want to start out on definition. This is a basic thing, but maybe a little counterintuitive. It's not always that clear. To define underinsurance and how we determine that someone is underinsured and any particular national trends. Sarah, can we start out with you? When you think of the term underinsurance, what does it mean? How do you figure it out? And are we better off or worse off these days?
Well, an underinsured person, the way the Commonwealth Fund has defined it, is someone who has health insurance but has a health plan which leaves them exposed to potentially high healthcare costs relative to their income. The fund developed a threshold measure for underinsurance using our biennial health insurance survey, which we've been fielding since the early 2000s. We define someone as underinsured if they have been insured all year, but had out-of-pocket costs that amounted to 10% or more of their income, 5% or more if they have low income, or if their deductible was 5% or more of their income. According to our latest, sorry, go ahead.
So could you say those again, those three?
So we define someone as underinsured. So our threshold measure is people who were insured all year, had 10% or more of their income going to out-of-pocket costs, 5% or more if they have low income, so under 200% of poverty, and their deductible is 5% or more of their income. If people met any one of those three indicators or thresholds, then we would count them as underinsured in our survey.
Good, thanks for repeating that, thank you. And so tell us more about where we're headed then.
In 2020, which was in 2020, our latest survey. We have our 2022 survey is going into the field this month. 28% of people with commercial insurance, so either employer-based coverage or coverage through the individual market or the marketplaces, were underinsured by this measure. This is up from 19% a decade earlier. The biggest growth in the share of people who are underinsured over the last decade has occurred in employer plans. And this has really been driven by the proliferation of and the growth in the size of deductibles relative to people's income. But still, if you look at our data, and we have a chart that I use quite a bit in presentations, the problem is still really challenging in the individual market. So people in the individual market or the marketplaces, despite the reforms of the Affordable Care Act, are the most likely to be underinsured. And the cost-sharing subsidies, the comprehensive benefits has helped significantly in that market. But the subsidies that really reduce people's deductibles and cost sharing are really at the very lowest income group, and just a lot of people just have really high deductibles in that market.
So we went, and like you have got a 3-tier definition. We went from 19% to now 28%, I think I heard you say. And then the biggest contributor to that was in the employer plans. And among those plans, it was the size of the deductible that made the biggest difference. Is that what we heard?
That's right. And you have to remember kind of the limitations of our measure. We look at people's out-of-pocket costs, what they report in a given over the course of 12 months. And then we ask them about the size of their deductibles. So we don't know about other aspects of their benefit packages, but the deductible is really an indicator of risk. So what people might have to spend if they were to get sick and need care. Out-of-pocket costs are more retrospective, obviously, what people actually spent. Yeah. And the growth really has been in the risk. It's really been in the deductible side.
Got it, good. So I'm wondering, Amy and Katie, if you want to contribute to that. I know, Amy, you look primarily at the Medicare population, but in light of the figures that Sarah just quoted and any trends you're seeing, we'd be interested in hearing that. Same with Katie, what else you might be seeing that's telling us about the magnitude and the direction of the problem. Amy?
Yeah, I mean, everyone who calls PAN or visits us online is by definition underinsured. And as we know, for a Medicare beneficiary, the charitable foundations like PAN are really the only place that they can turn for financial assistance. So when someone needs assistance from PAN, they either have commercial insurance or they have federal insurance. And for the most part, we are serving a Medicare population. We're seeing that the people who need assistance are between 150% and 400% of the federal poverty level, but it's really skewing at the lower end of that spectrum. So the people that we are helping are seriously ill. They're often living with multiple chronic conditions, and they have limited income. I mean, you think of the I hate to use the word average, but the Medicare beneficiary whose average household income is $26,000. With that kind of income, it's really hard to be able to afford, as Sarah alluded, a high deductible and often thousands of dollars in out-of-pocket costs to afford their specialty medication that they truly need. For many patients, these are life and death situations.
So Amy, is PAN in a way kind of a barometer, as it were, of kind of where this problem is heading? Are you getting more calls? Are the types of calls sort of skewed in one direction or another? I mean, it was notable that you said you get people from between 150 to 400% of poverty level, but it had certain kind of skews or subgroups to it. What's the barometer telling you, at least from PAN's standpoint?
Yeah, I think what we have seen year after year is that the need for assistance far outweighs our ability, or truly any charitable foundation's ability, to support that need. simply not a sustainable long-term solution to solving this problem.
Right. You only have so much in the way of charitable funds to give out, and you get pressed harder every year, it sounds like.
Exactly. I mean, we're enormously grateful to our donors who support these programs, but at the end of the day, you know, it's often that these programs open and close multiple times a year. Sometimes programs open at the beginning of the year and maybe they are unable to open for the remainder of the year. So it presents enormous challenges for patients and for their providers to maintain continuity of care.
Absolutely. Katie, any other observations about where underinsurance is and where it's heading?
Yeah, so just quickly, I will say there is a little bit of good news in this regard. And in that, you know, it might not feel like it, but there has been data recently published by the employer benefits consulting firm Mercer that has shown that deductibles for some employer-sponsored plans have actually decreased a little bit. I think that is probably a result of some policy changes that occurred in late 2019 to repeal the 40% Cadillac tax on health benefits above a certain amount, which unfortunately, so that passed in 2010, and unfortunately that really was kind of the foot on the gas pedal of employers moving to higher and higher deductible plans. And so with the repeal of that tax, you know, I think we're starting to see that on the policy front, that deductibles have gone down a little bit. Hopefully that's sustainable. But in the meantime, a lot of the work that the Smarter Healthcare Coalition has been doing has to try to make the care that is offered on a pre-deductible basis, to expand that and to make the benefit designs smarter.
Got it. Good points. So I want to ask this then. When people, this is about the behavioral response. When people are underinsured, how does that affect their healthcare decision-making or even their non-healthcare decision-making? What happens to people who are in that state? Sarah, do you have any thoughts about how it affects individual or family decision-making?
You know, just based on our survey research, so we ask about underinsurance in our survey, but we also ask about cost-related access problems and also medical bill problems and the consequences of them. And what we found, you know, repeatedly every year is that people who are underinsured report rates of avoiding or delaying care because of costs at twice the rate of people who are insured but not underinsured.
Twice the rate.
Yeah. I think the new post that Mark Fendrick also published at Health Affairs shows that copays for cancer screening lead to delays in cancer diagnosis and increased risk of mortality. And we know this is true. We know that high cost sharing and deductibles lead people to make healthcare decisions that are not in their best interests. So it's potentially lead to worse health outcomes as well.
Yeah. Amy, what are you seeing? I know that when people call you, they've got other problems too. What are you detecting along those lines?
Yeah, it's, you know, we do a lot of polling at PAN of our own patients, and we do a lot of polling across the nation as well. And we know, and this is no surprise, that people are making unfortunate decisions when it comes to their health care, and, you know, having to choose between paying for that medication at the pharmacy counter or putting food on their table. We did a poll, I want to say it's about a year and a half ago, and what we found was that they are making unfortunate healthcare decisions. They're either, you know, using their prescription in a wrong way. They're spreading it out just to make it last longer. We found that 1 in 5 seniors were prioritizing their conditions, especially if you had multiple conditions. They would say, well, this condition may be more important than these, and so I'm going to fill these prescriptions, but not those. Or they might be delaying getting care. We also saw that half of the individuals that we polled just simply were unable to do other things. They had to cut down on their food that they bought for their family members, or 1/3 had to tap into their savings, which is an unfortunate situation. One of our most recent polls, which was conducted nationally at the end of 2021, and I'm reminded by a statistic that I think Mark Fendrick shared at a former summit, where at that point in time, we found that, on average, people have about $400 in savings when they are faced with an emergency or a terrible health situation. Well, we asked a similar question and found that 1/3 of adults have less than $100 that they could tap into if they were faced with this emergency. So it's a real concern. And these are the same individuals who are concerned about their housing costs. They're concerned, every week they get concerned about putting food on their tables, and they're concerned about not having reliable transportation to get to their providers. So it's not just the financial burden of being able to afford care, but it's looking at some of these broader social determinants that really have an impact on access.
It's so interesting, Amy, because we just had a session on supplemental benefits, and they were about food and housing and transportation. And so you're getting people that really are in greater need of those particular benefits. Medical debt. I don't know if this is a Sarah thing or a Katie thing or an Amy thing, but where are we these days with medical debt? And I know that there's a lot of kind of ambiguous information out there on it. Sarah, do you have a take on that at this point?
I do. It's something that we've been following for a very long time. Also in our survey, we found that people who are underinsured have medical bills that they're paying off or over time nearly as high as people who are uninsured. Medical debt has really become endemic to our healthcare system. The media is truly awash in stories of patients receiving outlandish uncovered bills. The new report out last week from the Consumer Financial Protection Bureau found that about 1 in 5 consumers that have credit reports, and about more than 200 million people have credit reports, had medical debt in collections as reported on in their credit report. That's amounts to about $88 billion in medical debt total. And I think the attention to this, there's been a growing attention to really how outrageous this is, that people's credit reports are affected by bills that they often don't have much control over. Has led this week to the major credit reporting agencies, the 3 credit reporting agencies, making major changes in their reports and their reporting of medical debt. So taking those debt collection reports off of people's credit records, at least once they're paid, and also not reporting out small bills or small bills under $500. Which makes up 75% of medical bills that are reported to collection agencies. So we're seeing a lot of attention to this issue, and then some efforts, at least not on the causes of it, but at least on the effects that it has on people nationally.
The modification in credit reports, I literally just heard that this morning on whatever, NPR or something like that, just reporting that. So you're quite timely. Amy, then back to Katie on this. Anything else about insights on medical debt? Amy?
Just, I concur with everything Sarah has said. There's been a lot of reporting about this of late, and there needs to be. There's a recent report out within the last couple of weeks from, I believe, Kaiser, that indicated that 23 million Americans, or I guess it's 1 in 10 adults, had significant medical debt, and that was defined as at least $1,000. And clearly, medical debt can happen to anyone, and it's across all demographic groups. But I think the report found that it was particularly prevalent with people with disabilities, people with serious illnesses, worse health, lower income individuals who are living in the South or in the Medicaid non-expansion states. So it's a concern. And then on the heels of that report, I believe just this week, the American Cancer Society issued a report. They polled individuals living with cancer about medical debt, and they found that 1 in 2 cancer patients were living, 1 in 2 cancer patients living with medical debt, which, as you know, just lasts years and years. So significant problem.
Had not heard the 1 in 2. That hurts. Katie, anything on medical debt? And then move to 2 other issues.
Yeah, so I would add here, there is good news. At the end of 2020, Congress bipartisanly passed the No Surprises Act. Yes. To end surprise bills in the majority of cases. And so that law limited patient cost sharing to no more than what they would pay in network, even if they're taken in emergency to an out-of-network hospital, or maybe they are seen in an in-network hospital by an in-network provider, that maybe an out-of-network anesthesiologist or radiologist or pathologist. And so again, those protections became effective on January 1 of this year. They were provisions passed bipartisanly by Congress, signed by President Trump, implemented by President Biden. So it's really positive news. I think importantly, the law really does work to address some of the market failures that have kind of gotten the country into the pickle of surprise bills and just flawed incentives that really led some certain providers to go out of network. Certainly not all providers, but some providers were going out of network. And so I think that will really help address the issue of medical debt. Unfortunately, ground ambulances were not included in that legislation. And there continue to be some additional areas that have room for improvement. But I think it was a really positive step that Congress took.
So 2 glimmers of hope then, Katie. One is the credit report thing we just heard from Sarah, and then the No Surprises Act. So glimmers of hope, not solving it, but still helpful. 2 main issues we still want to cover here. First to Amy. Amy, we want to hear from you about where we are with Part D in Medicare, like where is that headed? And then back to Katie Spangler on the HSA, HD, HP pre-deductible services, Katie. So Amy, give us kind of the big picture on Medicare Part D, and is this a case of underinsurance where we need to go?
Yeah, no, thanks for that. And, I'm now in my 9th year at PAN, and every year I've been advocating strongly, along with many, many other patient advocacy organizations and coalitions, to reform the Medicare Part D program, because I think those are incremental or maybe not so incremental steps that we can take that can really alleviate the financial burden. So the Medicare beneficiaries are the only insured group that don't face a cap on, what they pay out of pocket for their medications. There's unlimited liability. So for, the individual who is faced with paying for an expensive medication, they are catapulted pretty quickly into the catastrophic phase of the benefit cycle, where they're paying 5% of the drug costs. And I always say, 5% does not sound like a whole lot, but 5% of an expensive medication is a big number. And unlimited liability until you reach January 1, when the whole benefit cycle, restarts again. So, we want to lower those out-of-pocket costs. In addition, we know that, at the beginning of the year, people face very high out-of-pocket costs in January, February alone. So we have this notion of smoothing, which would smooth out these costs throughout the benefit year. There's been bipartisan support for several years for both the Medicare Part D cap and smoothing. It was included in the Build Back Better reconciliation bill. Obviously, that didn't get passed. It's tied up with conversation around drug pricing legislation. But we remain hopeful because there is such bipartisan support that this year can be the year where we can get these two provisions passed. It's very, very important, and patients have waited far too long for reform.
No kidding. It's like your 24/7 issue, I guess, Amy. It's like stay on top of Medicare Part D and so forth. And that whole 5%, getting to the deductible quickly, and what we know about what we mentioned, a few mentions of cancer before, these are not cheap drugs. And so 5% of 10,000, 20,000, 30,000 over months, maybe 100,000 is a lot of money, 5% of that. So it does contribute to the underinsurance. So Katie Spangler, there aren't a lot of people that are as expert as you are in this next topic. But when we're looking at employer commercial plans and the HSAs and the high deductible health plans and these pre-deductible services, we share with us what that has to do with underinsurance, where we're going with it. And there's something special called the IRS Notice 2019-45. And if we don't learn anything else today, we want to know what the heck that thing is, and you're going to tell us, I hope. Katie Spangler, where are we with this?
Yeah, thanks so much, Cliff. And I think a lot of the participants are probably familiar with this, but in case not, I'll do a quick 60-second background. So the Medicare Modernization Act, which passed in 2003 and actually created the Part D program that Amy just spoke about, also created this whole concept of health savings accounts. And in order to make a contribution or receive a contribution to a health savings account, you have to have a high deductible health plan that meets certain guidelines outlined by the Internal Revenue Service. There is a safe harbor that was written into that statute that allows for preventive care to be offered on a pre-deductible basis. So meaning a health plan or an employer could offer certain preventive care pre-deductible, and you would still be in compliance with the IRS rules. Unfortunately, when IRS opined on that section of the law way back in 2004, they took a really narrow view of what qualified as prevention. And so you could screen to find out if someone had a chronic condition, or you could screen to find out if someone had a disease. But then once they were actually diagnosed with the disease, none of the care could be offered on a pre-deductible basis. As we've heard about from most of the speakers in some way, shape, or form today, prevention, and particularly chronic disease prevention, is really important, not only from just a patient quality of life perspective, but also from a cost perspective, from an employee productivity perspective. There's lots of reasons. And so this is something I know the VBID Center and the Smarter Healthcare Coalition have been working on for a very long time. And we were delighted that in 2019, the previous administration published guidance actually expanding on that 2004 guidance and specifying that certain drugs and services could be offered on a pre-deductible basis. And so while that is exciting in and of itself, Cliff, I'm also just thrilled to tell you that their work has been done to survey employers and health plans and determine has this been successful? Have employers and health plans actually made changes to their plans to offer more chronic disease prevention on a pre-deductible basis? And the answer, Cliff, is a resounding yes. So between 75 and 80% of employers, according to a survey conducted by AHIP in consultation with the Smarter Healthcare Coalition, about between 75 and 80% of employers and health plans surveyed actually did make changes and offer more chronic disease prevention on a pre-deductible basis. There was a similar survey that the Employee Benefit Research Institute conducted that showed that 76% of employers made changes to offer more chronic disease prevention pre-deductible. When asked why they did that in the EBRI survey, a very high number of employers, specifically, I think it was 74% of employers, said it was because it was the right thing to do. So I love this. This is like the best example, Cliff, of if you build it, they will come. We told Treasury and IRS this in countless meetings leading up to that 2019 guidance. We said, hey, they're going to do this. They want to do this. It's the right thing to do. 90 cents out of every healthcare dollar go to manage chronic conditions. And so if we can catch those diseases earlier on and help people better manage them, we can make people will be happier, they will be healthier, they will be more productive, and ultimately, their care will be less expensive.
It's just
So
surprisingly,
it's a great success story.
it's surprisingly good news. I'm kind of saying like, okay, what's behind the curtain? Is that what they really said? But 75 to 80% were in favor of this. And then why? Because it's the right thing to do is a reason. It's just great to hear, and we want to kind of go back to that community for more. Can you give an example or two perhaps about specific services that have kind of come into use through this chain of events? Any particular preventive services?
Yeah, so two of my favorite examples, I would say maybe three, Cliff, are insulin for people with diabetes, methods for measuring blood sugar for people with diabetes, so be that a glucometer or a continuous glucose monitor, as well as inhalers for individuals with asthma, blood pressure monitors, so statins, a lot of just really high value things that help keep people healthier.
And the ones you mentioned, at least a few of them, really affect a lot of people.
Right, and what's great, Cliff, is that in the AHIP Smarter Healthcare Coalition survey, they actually asked what impact did offering this additional pre-deductible coverage have on premiums? And the answer was a resounding like 1% or less. And a lot of folks answered in the less realm. And so they were able to do this, and it hasn't had a big impact on premiums, which has been a concern of some policymakers, that the more that's allowed to be offered on a pre-deductible basis, the higher premiums will get. But in this case, it's such a great success story. I love to be the sunshine at the picnic today, Cliff.
But yet again, that's counterintuitive. I mean, I can imagine a lot of congressmen on at least one side of the aisle saying, we can't afford it, it's too expensive and so forth. Why is that? What's the math there? Why is that percentage so low?
I think a couple of things. I think the list of specific items and services that can be offered on a pre-deductible basis that was included in that guidance document, it's very narrow. There's 14 items and services. You have to have the condition, a very specific condition for which you could then unlock the pre-deductible coverage. And so that's one thing the Smarter Healthcare Coalition and the VBID Center are both asking Treasury and IRS to utilize the principles that they outlined in the guidance, but then open up and say that list of 14 items and services, that should just be an illustrative list of things that can very clearly be offered, but that if folks are kind of utilizing the spirit of an item being low cost and high value, that the plan or the employer really should have more flexibility to determine what they offer on a pre-deductible basis.
Okay, so that leads to my last question on this, if you don't mind, and that is, so what would be next? We got the 14. What's Katie, is your outlook for expanding upon that, and is that an uphill climb?
Yeah, so I think that removing that requirement that it be covered on that list of 14 drugs and services to just say, hey, plan, employer, you know your populations. If you, as we heard earlier, maybe you have a ton of asthmatics and you're in San Diego and, you need to do something specific to help that population. We want to give the flexibility back to the plan and the employer to decide exactly what should be covered. Cliff, unfortunately, the statistics are very sobering as far as the mental health concerns that have increased in this country along with the pandemic. And so, the example of offering more mental and behavioral health counseling pre-deductible, either by telehealth or in-person office visits, more drugs and services to help treat mental, behavioral health, substance use disorders, very important, highly proven clinical interventions. And we would just really appreciate that flexibility resting with the plan or the employer.
I would think that more and more employers would be willing to take that on.
Cliff, Every asked that question in their survey, and 81% of the employers that responded said if they had the flexibility to offer more pre-deductible, they would do it.
Well, I hope someone opens that door. So good gosh, thanks, Katie. So Sarah, having heard this discussion about the kinds of things that Amy Niles is putting on the table for improving Part D and what Katie just said with regard to the high deductible health plans and kind of the pre-deductible services, does that kind of thing make a dent in the data that you monitor from time to time? Is that going to make a dent? Is that going to have some impact one way or another on the underinsurance stats that you track?
I mean, to the extent that, I mean, the HSA high deductible health plan market is a growing segment, and so it is actually to the extent that people have choice, it tends to be a somewhat healthier group of people that are enrolled in those plans. So to the extent that they had underinsured problems is a question mark. They tend to be a little bit higher income, so they might not show up in some of our underinsured measure. But pre-deductible coverage, very, very important. I mean, most employers offer deductible exclusions for most of their health plans. There's a lot of that that's present in the individual market and the marketplaces. So one of the challenges is educating consumers about the fact that costs are excluded from the deductibles. Even preventive care that the ACA brought in, no cost sharing for preventive care services. A lot of people just don't know their plans well, and they're just not really aware of it, so they tend not to get care, even though it might technically be covered. So I'm not sure. I think that these are important steps. I think incremental steps like this are very important, and they do benefit maybe a smaller number of people, but they provide benefits. I think we do need to make some important strides in the individual market to reduce the cost sharing in those plans, and there are bills in Congress that would do that, increasing the cost sharing reduction subsidies, for example. And I also think we need to look at what's driving the growth in deductibles. Katie is completely right. There has been a flattening in deductibles over the last few years. We've seen that in our data, and Kaiser and federal data has seen that. But truly, what's driving this is the same thing that's driving premium contributions and premiums overall, which is our healthcare spending trends, and then what we know is primarily responsible for that are the prices that are paid to providers. So this is a very large problem that consumers are experiencing, and we can see the evidence of it, and we can address the problems they're having directly. But we also have to get at the cost drivers in the system and have a pretty frank discussion about policy levers to address those.
Fair enough. So here's
If
Amy.
I can just add on the Medicare reform, what's been on the table is a $2,000 cap on prescription medications, which still would be a challenge for many Medicare beneficiaries, but for those, as you alluded to earlier, on these very expensive medications, it would be a big improvement. But I think we have to remember, and there's been some conversation today about this, prescription medications, while critically important, it's one piece of one's total care. And so we really do need to look at one's total cost of care, totality, because what about the copays when visiting healthcare providers and for other services? So that's something we should be moving toward.
A lot of pieces to that. The $2,000 cap would help. It certainly would. But
yes.
Well, actually, Amy, that leads us to my closing question, if you don't mind, and that's this. Sarah set this up really well with the stats on underinsurance and a very clear definition on it and so forth. And she's been tracking all that. And Amy, you and Katie both have talked about either proposed or actual tweaks or fixes to the system, each of which can have an impact on diminishing the problem of underinsurance. But I'll ask you to be slightly philosophical at a 20,000 foot level here, maybe 50,000 foot level, and that is, can we appreciably fix the problem of underinsurance in America incrementally in the way that you have each proposed or have each helped carry out, or do you need a whole big fix overall? In other words, can we go about make substantial progress through an ongoing push for a series of fixes, or will that not suffice? I want to start with Sarah on this. Let's go Sarah, Amy, Katie on this one. Sarah, incremental, can we, is that enough progress?
You know, I think first, absolutely. I mean, it's not enough, but it's really important. And we need to protect consumers against high out-of-pocket costs, both through legislation and regulation. And I think the examples that have been brought up in this discussion are really important incremental changes. But again, just going back to what I just said, unless we address the root cause of these costs, prices paid to providers, the cost to the federal government of these protections is going to make them politically difficult to enact. So it's the incremental pieces are really important, but we also need to get to the root cause or the root drivers of the problem.
A pragmatic point well made. Thank you, Sarah. Amy, what do you think?
You know, I think ideally we all owe it to ourselves to work toward a system where we are thinking about the total cost of care, but also integrating the concepts around social determinants of health and health equity. It's vitally important, but we have no choice but to move toward incremental fixes. We have to do the things that short term, middle term is going to help those people who are underinsured. So we will continue to do that.
Okay, well, I'm sure you'll be at the other end of the phone at PAN taking all those calls, Amy, on so many people that are hurt by this. Katie, what's the outlook, incremental or other?
Yeah, hey Cliff, so next year will be my 20th year in DC working on health policy, and I spent about 10 of them in the Senate. And one thing that I absolutely learned is that, you know, incremental is the way to go. Keep things, as much as you can, keep things bipartisan, build coalitions of folks that aren't typically aligned, and do what you can to get it done. And, you know, that's what we've tried really hard to do with some of the work of the Smarter Healthcare Coalition, be it expanding the VBID demo and the Medicare Advantage program, be it the working to address social determinants of health, reduce low value care, or this most recent example that I walked through today about expanding pre-deductible coverage of chronic disease prevention. Sometimes it feels small, but I think, you know, every little bit helps. I think the more we can also do, to just echo what Sarah said about how important the price of healthcare is and how much the price has gone up. You know, in some instances, we've seen utilization go down or remain stable, but the prices are going up. And so that's the driver of healthcare costs. And so little things that we can do to decrease healthcare prices, I think, are really critically important.
Well, that's sage advice building on your 2 decades in this field with a bunch of successes, and may we all have another 20 years to work on the problem. I hope the problem goes away before 20 years, but I'll stick around for 20 if you have a good idea for how I can help, and I'd be partners with all of you in doing so. I just want folks to notice, by the way, that the issues that Amy, Katie, and Sarah have aired with you today, including the data, including the policy changes, all have multiple threads, one of which is still this aspect of enhancing health equity. If what we're going to try to do, as we've just talked about here in underinsurance is an example of health inequity. We talked about using social determinants of health, better data, policy tweaks, and so forth, partnerships, pulling in the employers, as we heard. All of these reflect on the sessions we've had earlier with regard to how we reduce healthcare disparities, the role of supplemental benefits. Gosh, it was just so clear, and was just reflected. I think it was Amy who talked about, you know, food, housing, and transportation. We heard a lot about that in an earlier session. How we go about reducing low value care, because low value care hurts people subject to disparities as well, and reduces available funding to do the right thing. And then wrapping this up with practical, pragmatic experience and foresight insofar as how we can keep pushing this forward. And I'm sure Sarah Collins will track it for us all the way, with Katie Spangler's glass is half full and Amy's ear to the ground with regard to hearing on a day-to-day basis what people actually need. So Sarah Collins, Katie Spangler, Amy Niles, thank you so very much. This is a great capstone for our 4 sessions today. Very much appreciated. And with that, I want to turn it over to our dear colleague, Michael Chernow. Dr. Chernow, over to you, sir.
First, let's see, Cliff, can you see me?
I can see you, yes.
Yeah, can you hear me? It's like a Verizon commercial. Hi, everybody. It is great to be here. It was really, I think you'll all agree, an absolutely wonderful day. I'll point out that the topic of the day, health equity, has gotten a lot of attention, but when Mark and I were originally talking about value-based insurance design, there's actually a lot of equity motivation behind that. The goal was to remove the financial barriers to high-value care, which I think you heard today has particular importance in the world of promoting equity, because those financial barriers can prevent access to the type of care that a bunch of populations need. It's disarming to see how much younger I am in that closing remark picture as I look on my camera, but I'm going to try and look away. In any case, when we started talking about VBID, there was this criticism that it was too academic, it was too nuanced, practitioners wouldn't care, we're never going to get anywhere. And so I'd like to point out on the agenda today, the only person, I may have this right, the only person who's actually in an academic institution now was Rita Redberg, and she's actually a real doctor. Cliff pointed out earlier that Dora and Lori are real doctors. I, by the way, am not a real doctor. And what was clear is that the policy community, the practice community, has really been able to take this nuance and move it into action. So maybe that's going to be my new buzzword about VBID or these conferences, nuance into action. But we saw this in the work that they're doing at CMMI, in the REACH model that Dora mentioned. The MA plans are doing with supplemental benefits is unbelievably important at achieving this goal and very consistent with high value services in a VBID sort of sense. There's a lot of discussion of the MA VBID program. The policy work and discussion around measurement of low value care is clearly important and something that we're going to need to do on a continuing basis if we're going to finance the high value care, or more broadly make the system fiscally sustainable. And again, a lot of what pushed us into VBID and the equity components of VBID was this notion that people that were insured, but they weren't, they still faced financial barriers to getting access to care. And that certainly is true post ACA, where we've seen a big increase in insurance, but we still face this problem of uninsurance that the last panel discussed. So to be able to see the group of people coming from the CMS, from plans, from a whole bunch of other stakeholder organizations participate today, and to know who's on the I'd say Zoom, but this is GoToMeeting, so I'm not sure what I'm allowed to say. But in any case, to see the attendee list being such a diverse set of people working in this space from so many different angles is really, really, really heartening, sincerely. So I will wrap up quickly and simply, first, I want to thank all the panelists. You were absolutely outstanding. For those panelists that are on, send a message to your favorite panelists and tell them what a great job they did. They were terrific. I want to thank the sponsors here. None of this would be able to happen without the sponsors. I don't think we realized when we started the VBID Center over 2 decades ago that would still be going now. But it has been, I think, a really important journey for patients, and I think it's been a very rewarding one. And it's only possible because of the support that the sponsors have given us. So again, if you're not going to thank the panelists, please thank the sponsors. Cliff, you do an amazing job every year. My general takeaway when Mark asked me how the meeting went is I could never do what Cliff does. So Cliff, genuinely, thank you so much. You are by far the best. One problem with not being in person is we can't all clap. The other group that is behind the scenes that does an absolutely amazing job is Susan Lin and the entire VBID team. You might think this is easy to pull together. Trust me, it is not. And the VBID team led by Susan Lin do an absolutely spectacular job of making this all happen. So thanks to them. The VBID Center, as I mentioned, is doing really amazing things. We had our advisory board meeting yesterday, and it is amazing the number of things such a small group can be in. And I think if you were to look at the impact of the VBID Center, it's punching well above its weight. And really improving the lives of millions of people in a whole range of ways. You can trace it back to Section 2713, to the MA VBID demo, to what they're doing now on high deductible plans and access to care there. So really, it's terrific. And so if you want to give comments, please go to visit the website at vbidcenter.org, send comments. And of course, last but not least, we have to thank Mark because Mark embodies the VBID Center and all of this work. So Mark, as always, you've done an outstanding job. You get credit by association for the wonderful panelists and for pulling together the VBID team and recruiting Cliff. So thank you all. Send your comments. We really do appreciate your time, and hopefully we'll be able to be in person sometime soon. With that, I think I'm going to say thank you, Mark. If you don't want to add anything, I'm going to say thank you and goodbye. And please, everybody, stay in touch.